Good morning, everyone. Welcome back. I hope everyone had a good night's rest. So I was supposed to introduce the center and what we do yesterday when I said my opening remarks, and I totally forgot most of it. I'm not sure why. But, so, this event is actually part of an initiative that we have called the Healing and Humanity Initiative. So the Center for Global Health Delivery is looking at this last mile of care delivery, and we've obviously understood that that care delivery involves care and involves healing and really thinking about how to and that last mile of care delivery is not just it's not just about what you physically do, the operational aspects, but it's really about the paradigm and the mindset that you're having as you go into it. And so that's the rubric under which this conference is being organized. We yesterday, I think we had some really good discussions, and we had I think we were I don't want to say provoked. I think we were stimulated by some of the things that came out in the discussions, and certainly by Dr. Emmanuel's talk and by Danielle Allen's talk, who also goes by Danielle Steele. But it was very, I think it was a very I think we had some important developments. I left the day a little bit disconcerted, only because I want us to, as we're thinking about healing and humanity, and we look back over the last 40 years, I think nobody wants to take away from the fact that there have been significant gains. I think we saw that yesterday in people's presentations. Many lives have been saved. It was in the millions, right? People were saying 4 million, 2 million, like really big numbers. But as we're thinking, here we are 40 years later, and we're thinking about the next 40 or 50 years, I hope that we are thinking about, the 25% of kids in East Timor who still get rheumatic heart disease, that need a vaccine, that need to have some AI approach to looking at their heart valves, who need access to penicillin, like really basic stuff. This isn't, we talked about these rare cancer drugs and things like that, down that slippery slope of decision making, but just really basic things. Or we heard from Karen about the large proportion of people who are going to need care for elder care and for dementia. And the 700 million people that are about to have diabetes and will need care so that they don't go blind and have an amputation and have more pneumonias and need renal dialysis. And so, I'm hoping that we're going to today really think about building a system that will serve that. And I hope that's going to look different than what we did in 1978, because the system that emerged for various political reasons that people have brought up doesn't do that. And so, I hope today we'll be able to do that. So before today we're gonna start with Dr. Ray talking a little bit about David Sanders, and then I'm gonna hand the floor over to Professor Arthur Kleinman, who's the Rab Professor of Anthropology and Professor in the Department of Global Health and Social Medicine, who's had literally 50 years of experience working in the field in China on mental health and other topics, and now is looking at elder care and dementia and a number of other issues. So I'll hand over to Arthur after Professor Ray. Professor Ray, thank you.
Thank you very much. And I can't tell you how much I wish that it wasn't me standing here, but that David had been here, because I'm sure he would have taken the whole discussion we had yesterday in a very different direction. And I'm now daunted at the task of even giving you an idea of what I think his contribution to public health and child survival are. I'd like to recognize Professor Mary Bassett, who's here today, who was also with us in Zimbabwe and was a leader in initiating HIV research and in the whole gamut of public health interventions. Okay, so rather than just telling you how great David was and all the wonderful things that he did, and also how wonderful his wife was to tolerate him rushing around the world at the rate of knots. He was supposed to be here this week. He was in India. He was supposed to be in India last week. He was somewhere else the week before. I wouldn't claim to say that any of that contributed to what we would now think of as his premature death. But obviously trying to save the world is quite a stressful, or can be quite a stressful situation. Let me just tell you a bit about him for people who don't know him. This is a great picture that Mary found for us. of David. So he was 74. Great, thanks. He was 74. He just turned 74 when he died. Okay, this is a bit dense. I'll just summarize it. But he basically, his connection with Zimbabwe was that he comes from a medical family in Zimbabwe. The house he grew up in actually is now the UNICEF headquarters, just opposite the main teaching hospital in Harare. So he was a pediatrician, and he also did public health, and he worked in both in Zimbabwe. And then in 1993, he left Zimbabwe. He worked there for 12 years after independence, and he left really because he was struggling with the way in which things were going even then. But what happened in the 80s with Gukurahundi and the massacres of at least 20,000 people in Matabele land was something that many of us were very disillusioned with. And he went via Natal to the University of Western Cape and actually set up the Masters in Public Health program there pretty much from scratch. And he did that through fundraising, getting grants, and by doing consultancy work. And I think that if you talk to young Black academics in the region, many of them went to UWC and learned a lot about social justice from that university. And then he was a leading person in setting up the People's Health Movement. These are all his achievements. He set up this rural health program, which is actually how I was recruited. He recruited me in Oxford to come out to Zimbabwe in 1983. Several other people who also went on to work at WHO, etc. So this link with child survival, nutrition, agriculture goes back a very long way. He wrote a book called The Struggle for Health, which, even though it was published in the early 80s, he'd been working on while he lived in London before independence, and wrote more than 200 scientific articles. His last paper was in the Lancet on the 24th of August. And Sue Focus, his wife, tells me that he was very proud that he was able to write this paper. And as it turns out, it was shortly before his death. Because he was very disturbed by the declaration of Astana, that it seemed to be going backwards. And the title is One Step Forward, Two Steps Back, because it now, in focusing on health services, was not paying attention to social determinants. And he saw that that was going backwards. I've put into this, because people may want to look at some of his writings later, some of the key things. So if you look at this, this whole thing about the movement from Alma-Ata towards neglecting social determinants was because he was convinced that for us to get health gain, we really need to look at social determinants. And Farai, David, and I wrote a chapter in a book about cholera in Zimbabwe, and just in this last year. And it was very clear there that even with health services, because in Zimbabwe they were very proud that with this recent cholera outbreak in 2018, that they didn't have 4,000 deaths the way there were in 2008, because the public health services really kicked in and saved people. But the issue was that the epidemic should never have happened. And it happened because of complete neglect of the water supply. It's been well known that the boreholes in Harare that serve the poorer areas are contaminated. And that's exactly the situation that's played over and over in different parts of, well, the world, but in particular, I think we're facing this catastrophe in Africa, that the water supplies are not being looked after. In many countries, it's still the colonial infrastructure that's being relied on. People live in terrible housing. In Botswana, which is considered a wealthy country, it's upper middle income, if you go to Gaborone, you'll find the poorer housing, they're still using Blair toilets. In other words, they're not on main sanitation in the middle of the city. So you have a very rich house, and next to it you'll have 2 or 3 houses where people have to go outside to an outhouse for sanitation, as they did in 19th century Britain or Europe. So his comment in this paper in 2004 was that without macroeconomic reform, it's not only unlikely that the MDGs will be achieved for the poor, but it's almost certain that progress will not be sustained. So when we celebrate that 4 million lives have been saved, etc., are we going to continue to have that progress? The need for an equitable global economic system. Yesterday, we were challenged with this definition of equity, and I suppose from a public health point of view, we've always seen equity as being addressing the greatest need. And the picture that people showed of having a bigger step up if you're a shorter person is graphically the way people have shown it. But it's really saying, in order to have health gain, we have to identify where the greatest need is and to try and focus on that. And so he was very concerned that we were not making progress towards the regulation of the market, which is causing people to become ill now. And when we talk about the diabetes epidemic, what is driving the diabetes epidemic? It's type 2 diabetes, and it's very much underlaid by the whole nutrition issue. And so, of course, he was concerned about neoliberalism and the relationship with nutrition. And so these are just some of the things from his publications that the food price rises have resulted in 50 million more people becoming hungry in 2008. And the issue about food security is linked to the whole way in which more and more countries are importing food. And here's some of the statistics. So transnational companies being the leading traders of food, that 40% of food imports and exports are actually between these transnationals. And it's very stark when you go to South Africa. That you'll see people in townships, similarly in other middle-income countries, Namibia, Botswana, that they actually, when people want to treat themselves, they will go and have Kentucky Fried Chicken or whatever. Usually not Nando's, but the kind of battered fried stuff. That's seen as a treat. Drinking Coke is a treat. So as people move from traditional foods, they're actually becoming more and more exposed. So these are from David's slide set showing what's in Oreos. And you'll see that there's quite a lot in there that people don't often realize. In particular, this issue about palm and soy oil, etc. High fructose corn syrup, which is supposed to be one of the biggest drivers of the whole diabetes and obesity problems. The change from traditional foods to fast foods. Overweight and chronic disease in rural South Africa, this could apply to many parts of Africa, that in some studies they've shown 51% of women are either overweight or obese, and diabetes is around 10%. In Zimbabwe, a study was done which showed 10% of the adult population has diabetes also, or is pre-diabetic. Hypertension in a quarter. So what are we going to do about all of this? And so one of the issues is about community health workers, and certainly in the fields I work in, there's a lot of concern about the emphasis now on community health workers because of the fact that doctors dominate the way people think about health services. And at best, it's just a concern about whether people are skilled and supported enough, and at worst, people are trying to protect their own territories. And I have to say that I'm very dismayed by this. Certainly learning from the Asian experience, just simple interventions. We used to talk about salt and sugar solution, but actually now even administering antibiotics for pneumonia, these would have a higher impact when actually you can see that doctors working in primary care, because they're mainly private practitioners, are actually driving antibiotic resistance. So it's not the community health workers who are going to be driving resistance, it's inappropriate prescribing by medical practitioners. And then I'll just end on this picture, which is, I hope you can recognize David, that's him there. These are all his adoring students and people he's mentored. through the People's Health Movement, which is really the kind of movement that he was trying to encourage people to put their efforts into, mainly because civil society organizations need to address these problems and challenge the market system that is pushing ill health. So that's my tribute to David. I hope I've done justice to him.
Well, first of all, let me just say that I met David Sanders in 1993 in Cape Town when I was giving lectures in Cape Town. I was very impressed by his inspiring visions. He had just come to the Western Cape University, as I remember. So I think this was, it's sad that he's not with us, and it's important that we remember who he was and what he did. And that's quite relevant to what I want to say before we get to our speakers. Regrettably, I couldn't join you yesterday, and that's because I had a major project on social technologies for elder care in China, and we had the meeting with many students who were participating in that project. But I'm reminded of the fact that yesterday, from what I've read and what I've heard, has revisited many of the same issues in the relationship of the wider social world to public health that those of us who've been doing health for 50 years have heard repeatedly over time. What we don't hear repeatedly over time is an honest assessment of the quality of actual primary care around the world. And that assessment can be summarized in one straightforward American word: lousy. The quality of care everywhere in the world is poor and getting worse. And not only is it poor in the setting of professional care, it's getting worse in the setting of family care, which is, when you look at where most care is given, the real setting of care, the existential setting of care. So the great existential threat to this area, I think, wasn't discussed yesterday, and that is the fact that care is disappearing. It's disappearing for many of the same reasons that we see health impacted, that were discussed yesterday and will be discussed today. And actually, the summary we had here shows many of the factors that affect health status and mortality, et cetera, are also the factors that affect what's happening to caregiving in our time. And the only point I want to make here, since I don't have any time to go through this, but I have written a book that's just out now called The Soul of Care about it, and had a piece in The Lancet recently about it. The only point I want to make is that with the loss of care goes the loss of the human. The loss of the human. And one thing that has always bothered me, frankly, about public health, I'm a social medicine physician, has been an inadequate attention to the human. A tremendous concern, and rightly so, for mortality, for the conditions of health, but not enough attention to the human, to the quality of relationships, to what happens when dignity and respect are absolutely absent in caregiving. What happens when the acknowledgement and affirmation of the person who's come to receive help is not there? What happens when there's no explanation and no listening and no real human interaction? What happens is that something that we would never accept in our own care, but we accept routinely in care given elsewhere. I've spent my entire career studying care in China, and I can just tell you that care in China is appalling. At the same time that China has done some extraordinary things, no society in the world has had the success that China has had in the limited time of literally 40 years since economic reforms, of improving the prosperity of the nation, raising 800 million people out of poverty, 200 million out of absolute poverty, but at the same time having a failed healthcare system. So whatever you read about China, China has no primary care. There's no primary health care in China. The Chinese write about it, but it doesn't exist. And the reason it doesn't exist is the tail end of the barefoot doctors story, which is that the barefoot doctors were good at public health tasks, but lousy at caregiving, frightening in the care they delivered. Hence, the long tail of that is suspicion that any low-level practitioner can deliver quality care. The result of that is that when you get really sick in China, you go to see experts at tertiary care hospitals, you flood the hospital, and people are seen in less than 5 minutes. In less than 5 minutes, you cannot give adequate care for virtually any kind of chronic disease problem and for most acute disease problems. Anyway, that's what I just wanted to say that, and say that we tend to leave this out of discussion because we're unwilling to see that the rest of the world deserves the care that high-income countries have. Well, so now let's get on to the program, and it's my pleasure to introduce. We're going to have a film now, I guess, since Refat Atun cannot join us. Is someone going to present the film, or what's? Okay, great. So let's have Refat.
So, good morning. I'm Refat Atun. I'm professor of global health systems at Harvard THN School of Public Health. It's a real privilege to contribute to this conference on Reconceptualizing Health for All, the Alma-Ata Declaration and the Future of Global Health. And the title of our session is Universal Health Coverage versus Universal Health Care. That requires rethinking of universal health coverage. So I'm going to spend the next few minutes taking us through some of the challenges that we face in relation to universal health coverage or universal health care, then discuss the innovation paradox that exists, that is a barrier to achieving universal health care, and then the transformations that need to happen in order to achieve meaningful universal health care. The big challenge, or the biggest challenge we face globally in health systems, or more generally, is the widening inequalities. And there have been a number of publications that demonstrate clearly the breach of the social contract worldwide, ranging from publications by Thomas Piketty to those by Joseph Stiglitz. And the inequality is not just in terms of income or wealth, it's also impacting on health of individuals. So if we look at first the widening inequalities in relation to income, comparing what is being achieved in 2014, or the latest year, in relation to what was achieved in 1980, even in European countries, or the OECD countries, the Organization for Economic Cooperation and Development. In many countries, the inequalities, mid-1980s are shown by the diamond. Compared to what was being achieved in 1980s, in almost all countries, we can see actually a worsening of the Gini coefficient. So there is actually widening inequalities, even in countries that are committed to generally in reducing inequalities in relation to income, but also in relation to wealth. And in addition to the widening inequalities, many countries are actually have increasing amounts of debt. And this is a breakdown by regions of the world, comparing the debt levels in 2007 to 2017 in terms of cumulative average growth rate. And we can see that in all regions of the world and countries, there has been an increase. That puts a great constraint on countries to invest in health, because the debt burden means that the debt needs to be serviced, and much of the investment that could go into health is instead being used to pay back debt. So achieving universal health care is going to be challenging, given the widening inequalities, as well as the limited fiscal space available to countries. And we can see some of the impact of these constraints already in countries. If we look at European countries that have achieved universal health coverage, this is looking at access to care. This varies substantially, both between countries, member states of the European Union, but also by income groups. And we can see that the unmet need for medical care due to costs, distance to travel, and waiting times vary substantially in the EU28 as a whole, but in almost all countries, with Austria and Slovenia doing particularly well in relation to having the least difference between the high-income groups and low-income groups. So when we talk about universal health care, we need to ensure that the distributional issues are appropriately addressed, that healthcare access and access to effective healthcare is truly universal, and then we reduce these gaps. So this is access. If you look at what's happened, again, I'm using Europe as an example because these are countries that have achieved, countries in Europe have achieved universal health coverage. If we look at what happened between 1980 and 2014, if we look at the trends in all-cause mortality stratified by education level of the individuals, if you look at relative index of inequality, both in men and women, between 1979 and 2011, we can see that in almost all countries, the relative index of inequality has actually worsened. So we're seeing, on the one hand, widening inequalities in income and wealth. We're also seeing widening inequalities in access and widening inequalities in relation to unmet need. We're also seeing the important consequences of this in relation to all-cause mortality, widening differences between those who are better off, better educated, and those who are less well educated. And this is in a region of the world that is very well off and where universal health coverage has been achieved. So we have a big challenge. So unfortunately, much of the discourse in relation to universal health care has really focused, or UHC has focused very much on universal health coverage. So coverage itself is not enough. We need to have not just universal health care, but we also need to ensure that the health care is equitably targeted to those in greatest need. And we focus on reducing inequalities. But we have a big challenge in relation to the innovation that's happening in health systems. Because in health systems, even in countries that have achieved UHC, there's a sustainability challenge because health systems have become quite ineffective, quite inefficient, and highly inequitable. So let me try and demonstrate this. So I wrote an op-ed in the Financial Times a couple of years ago, commenting that while scientific developments have spurred unprecedented delivery of innovations in terms of new medicines, new medical devices, new health technologies, innovation in delivery of care has faltered. And that's a big challenge because we have a misalignment, this paradox between more technologies being available, but us not being able to deliver these to individuals who need them. So health systems need to change to provide effective, universal health care. The consequences of this misalignment are many. For example, in relation to inefficiency that I mentioned, again, using Europe as an example, as the region that has sort of good data in relation to efficiency of the health system, compared to the efficiency frontier that is being achieved by certain countries, many member states of the EU28 actually fall well below this efficiency frontier. So we're not using the resources appropriately and effectively to achieve health system outputs. Indeed, if we examine a WHO publication in relation to the efficiency of health systems and amount of waste, due to inappropriate intervention mix, the World Health Organization estimates across the world that the potential gains in health budgets, or loss, but what the potential gains could be between 10 to 20% of the overall health expenditure. And inefficiency in the delivery of these cost-effective interventions means that there are losses or potential losses in terms of human resources between 7.5 to 15%, in terms of procurement and supply chain management between, again, 5 to 10%. Very high figures. So overall, the the potential gains due to the existing inefficiency in health systems is between 20 to 40% of current expenditures. If we are going to achieve universal health care, we need to fix the efficiency problem and the innovation paradox that currently exist. But systems are also ineffective, as well as being highly inequitable. So this is a paper we've published recently, actually this year in PLOS Medicine, looking at diabetes care cascade in 29 low and middle income countries. And the surveys that were at individual level and national representative surveys are in 2015 or nearest. And for every 100 individuals that have diabetes, only 64% are detected, only 48% are diagnosed, 45% are started on treatment, and only 30% are controlled. And many of these countries actually have coverage, especially middle income and upper middle income countries. Yet, universal healthcare is clearly not being achieved because the control levels are very low, 30% in the case of diabetes, one of the commonest non-communicable diseases. And the cost of this is quite high. Globally, estimated to be 1.3 trillion, amounting to around 1.8% of global GDP, projected to increase if we continue using the same models. The levels are projected to increase to almost $2.5 trillion, around 2.2% of global GDP. So a huge cost, which creates a burden on countries, but also on health systems. And this is just diabetes. If we look at hypertension, we see an even worse picture, the commonest non-communicable disease. Again, this is broken down by regions. This paper was published in The Lancet 2 months ago, and we analyze the care cascade actually in 44 countries rather than 41. And we can see in Latin America and the Caribbean, control levels are only around 20%. In Middle East and Central Asia, it's less, around 15%. In South and East Asia and in Sub-Saharan Africa, levels go down as low as 10% or even below. So there's a real challenge in relation to universal health care and the kind of effective care people are receiving, and the inequity that exists both between and within countries. So when thinking about universal health care, I would say, I think universal health coverage clearly is not enough. Much of the discourse has focused on entitlements in relation to financing or insurance coverage. But without highly efficient and effective health systems, one is not going to achieve universal health care and universal health outcomes. So when we are rethinking about UHC, we have to think about achieving a balance of health system objectives. We need to have healthcare that is highly effective, that is highly efficient, that is highly responsive to user needs, but also care that is highly equitable. So we have to reframe UHC to achieve value for money, being efficient and effective, but value for many, being responsive to needs of all and being highly equitable. How do we get there? So fighting inequalities globally, we need to think about inclusion, investment, and innovation. So we have to rethink the societal values that shape our thinking of UHC. So UHC and investments to address the social and, more importantly, the structural determinants of health are needed to address the societal failures, which have particularly neglected the neglected, those individuals who are, whose income levels are low, whose education levels are low, who are in the lower socioeconomic strata. As a result, we have widening inequalities. So universal health coverage is not enough to address this. We have to achieve universal health care that is highly effective, that is highly efficient, that is highly responsive, and that is highly equitable. But beyond, we also need to focus on addressing social and structural determinants that lead to these wide inequalities and inequities that we observe in different countries. So we have to completely rethink UHC from coverage to care, but from care to universal health, ensuring equitable health outcomes, not just access to equitable healthcare services. So how can we do that? So we need to redesign public health and health systems. And public health and health systems need to be integrated. So we need to rethink about organizational design. In many countries, public health functions separate to functions that produce health services at individual levels. So we have to think of multi-sectoral action through integrated networks that simultaneously focus on individuals, but also focus on populations and their health. We have to transition towards integrated financing for health systems, public health, and also for social sector, to ensure that we are addressing not just healthcare delivery issues, but we're also addressing more upstream social determinants, or even more upstream structural determinants of health. And third, in relation to service delivery, we need to think not just supply-side solutions, but also targeted demand-side solutions, how we can mitigate the barriers to access to effective healthcare services by individuals who are in the lower socioeconomic strata, who find it difficult due to cost, geography, and other reasons to access these healthcare services, even when they're available. The services need to be not just available, they need to be affordable, they need to be accessible to individuals who need them when they need them. So going forward, we have to redefine UHC from universal health coverage to universal health care to actually achieving universal health outcomes. That's the challenge for global health. Thank you very much for your attention.
Well, Refat is not here to respond, but I think we should have some questions and discussion. How about some questions? Saturday morning early, everyone is simply digesting their food, their breakfast. Yes, please.
I have a question. I mean, I think that he was, at the end, he was raising the same content of.
Yeah.
And I wonder if we could reflect together a little bit longitudinally, historically, about the evolution of this question through over the last 40 years since Alma-Ata, and you know, maybe what we've learned since the initial push to globalize primary health care, and where that leaves us at the present moment.
Okay, well, we can open it up to that question. Let me just say that I think Refat did a marvelous job in avoiding the word quality. You notice that he was very honest. We have no direct measures of the quality of care. No direct measures of the quality of care. We don't use any. We use institutional efficiency and substitute it for quality. And if you listen carefully to Refat, he only talked about efficiency or inefficiency, responsiveness, but not quality. And I think that the issue that you raise would take us for another conference to look at what's happened. Why don't we have direct measures of quality? But let's have some. Yes, over here, please.
I did a terrific job of demonstrating what are the challenges and the problems. And I was on the edge of my seat waiting for his suggestions of solutions. And so I was very disappointed in that he didn't say something, because what he had laid out is I mean, there's no money because everybody's in debt. I was also very disturbed because he had many of his graphs. They were using indices and measures that I could not read because they were so small or I didn't understand. His use of technology and the inefficiency in the use of technology.
Yes.
knowing something about mobile phone and other kinds of technology for healthcare, having been a co-founder of a mobile phone app for developing countries, I'm kind of interested in this. But I wish he had had some suggestions.
Yeah, let's pick up on that a bit, because I think that's I thought the talk was very interesting, but I came to the same conclusion you did at the end, that there weren't many suggestions. But take one problem that he addressed. Let's take hypertension. Okay? If we look at the United States, the major problem with hypertension is that 3/4 of people do not adhere to the medical regimen. That is, even if you have care, 3/4 of people do not adhere to the medical regimen. So that this is a much more complex issue that would get us into the quality details than can be observed simply on the level of efficiencies and responsiveness. Up here, Mary Bassett, yeah.
I wasn't here yet yesterday.
Yes.
So I haven't heard the kind of debates that have occurred, but looking at hypertension, for example, from a public health point of view, something we have to acknowledge is the presence of sodium in the diet, which results in the United States in the majority of adults consuming more than the recommended amount daily. And as the food supply of developing countries has been increasingly commercialized and controlled, as the slide Sunanda showed, by transnational corporations, the diet has also shifted in these countries. So I just think that we shouldn't talk only about clinical individualized care without acknowledging the drivers of diabetes, hypertension, that are amenable.
But this whole conference has talked about the drivers and the big picture. I think it's the fact that we leave out the clinical component that's characteristic, in my experience, of public health discourse.
No,
Public health has been overwhelmed by the concept of prevention, and rightly so.
Well, it's not working.
But it's not working. But care is crucial, and that's the difference between social medicine, in my view, and public health.
Well, I would disagree with you on this, but that's another that's another
But look,
conversation.
you want
a
chairman to generate disagreement, so please.
Well, no,
please, my whole purpose here is to do
absolutely
this.
agree with you, having spent a big chunk of my working life in a setting where clinical care and public health were connected and overseen at the local level by the same people.
Right.
I agree with you that this idea that if you're sick, we don't care about you, which characterizes some people in public health, that you're simply a failure of our strategy, is incorrect. The access to care is among the social determinants of health, but it was interesting to me that he invoked rising inequality without talking about the social policies that have led to it, something that David Saunders would have been reminding us of, and perhaps some people here will as well.
Great.
As though it was just a natural phenomenon, including the rise in high blood pressure, the rise in diabetes, which are not going to be solved in the clinical setting alone.
No, but will not be solved without it. Let's have some other responses. Yes, please. Wait for the microphone. Yeah.
One of the factors that we haven't discussed that I think is a very important impediment in going from coverage to care is the global shortage of trained healthcare professionals, particularly in countries like, or continents like Africa, where there's an effort now to increase coverage, but without the trained professionals to provide the care.
Good point, and I'm hoping we'll hear something about this when we get our keynote later today from Vikram Patel. Yes.
It struck me that this presentation was eminently technocratic and apolitical. And it just demonstrates the perils of taking the politics out of these discussions. I mean, here we have, short shrift attention to structural determinants at the end without really delving into what that means, and moreover, never a mention of either the public or where profiteering fits into this larger picture, which I think is an absolutely crucial question in our debates. And just to give one example, the Gini coefficient data he showed had nothing about certain countries in Latin America, which since the 2000 approximately, actually experienced an enormous decrease in inequality through concerted policies, redistributive policies, and so on. Brazil, Uruguay, Bolivia, and other countries. So I think so much of relevance was excluded and is very telling about this kind of approach to either universal health coverage or care with the politics wiped out.
I think if you know, in all fairness, if you know Refat, you know that this is a technocratic approach. It's not about the political, and I think your point is very well taken. We had some questions up here. Yeah.
Putting my activist hat on and thinking about the remarks from Eric last night, I think the 3 points that Refat left us with around taking multi-sectoral action, pushing for integrated networks, financing, and actually providing care, proving that it's possible, are things that we should all be thinking about. Eric was saying how important it was to have the activists, but also to have the researchers and the lawyers and the doctors and everyone together. So I think for me, it was actually motivating to see, okay, here's a roadmap, but how do we make all these pieces come together?
Next, yes.
Yeah, thank you. I don't mean to get all Greta Thunberg on this group, but just to say, maybe echo one thing that she did say is, are we mature enough to tell it like it is? I would say on the weight of yesterday's conversation, probably not. And the reason I say that is because I think it was what hit on by Danielle Allen and Jean-Claude Magunga yesterday was that we need to address this point of collective rights framework and movement for global economic, migration, and health justice collectively, and we won't address this beyond academic circles if we do not do those things. And so I just want to say, when we get to talking about what are solutions, Julie, you just said we need solutions. Well, here's a solution. Maybe we prevent $2 trillion leaving the global south or the global north every year in illicit tax flows. That's a solution if we're willing to address it. If we're willing to just look at what money is currently can be mobilized domestically in the global south, we're not going to get there. And instead, we're going to come up with strategies, interim strategies, that will instead be based on what can we prioritize first. And that's self-fulfilling because it gives wealthy governments a way out to give a little bit of aid to stop people getting in the streets and dissenting and sustaining the status quo globally. So that's the tone like it is that we need to hear, and I hope there's more of that this morning.
So I hear that as a cry from the heart about the political. How about other responses? Okay, well, I think I'm sorry. Richard, yeah. You were so quiet there, Richard, I was wondering.
I want to reinforce what you said in your opening comments, that ultimately the care of most of the conditions make up 95% of what people have will ultimately be based in the home. Whether it's hypertension, whether it's diabetes, whether it's diarrhea, what I deal with, but so on, whether it's the treatment of tuberculosis. Yes, you can have a superstructure that will identify the problems, but ultimately if we don't recognize that, and that's where quality has to occur, we'll continue as we have. That said, I think we all ought to also recognize that there have been great improvements.
Yes.
And we need to look at why those improvements have occurred. I'm sorry, the sky is not falling. It really isn't. It's how to tweak it so it's better. But I think your opening comments were very, very important.
Thank you, Richard. Other comments? I see none. Oh, yes, please. Yeah.
Well, I'd like to just reinforce what's been said before about actually addressing the drivers. And in particular, looking forward to the younger people taking on this challenge of preventing money leaving the South. And we were very engaged with this idea of $34 a head in Ethiopia. And some people were using that as a justification for animal farms. Some people are more equal than others and therefore should have the right to heart surgery, rather than everybody having the right to antibiotic treatment for pneumonia. So these are the challenges we're faced with. On the issue of quality, I believe I did try and address it in my presentation, but we have to really look at why, if we're going to go down that route of saying we're sitting in a primary care clinic, and this is sort of the level that I've worked at most of my life, it's saying why would people not be giving quality care at that level? And there is an assumption that there is quality care being given in high-income countries. It's usually when people can pay for it. Why would that be happening? Somebody who's been trained as a health worker, why would they not give? And there's a whole there's a huge literature on why people may be providing poorer quality healthcare. And I think that what is coming out of the people's health movement, which is saying that there has to be a synergy between communities and the health professionals or health workers, where communities actually hold services accountable for the quality of care that they provide. But more than just being held accountable, it's actually saying that health workers, if they feel valued, are more incentivized to provide better quality care.
Yeah.
And that sense of being valued comes from the community. I think I showed in my slides that midwives were very energized by feeling that patients were satisfied with the work they gave. So the challenge is, how do we get that? Yeah. And I think that's what we have to strive for, because in our situation in Southern Africa, health professionals are working very hard, but they're unrewarded, they're unrecognized, they're undervalued. So why do we expect them to get up every morning and provide quality of care when what they can expect is to have somebody from the ministry come down and shout at them?
Yeah.
Okay, so that's what we have to turn around. And I suggest that it's through community activism, where people recognize the health professionals or the health workers in their midst working for their benefit. And so we sitting here need to be supporting communities to do that.
Yeah. On that very topic, I think some of the best work has been done by Jishnu Das at the World Bank with his mother, Veena Das, at Johns Hopkins University, in India, at looking at the real quality of care, both private and public, and what the drivers are. And I think some of them that you mentioned are absolutely right on. The one thing, and I fully support what you've said in general, but I would say that in a rich country like ours, the quality of care is also poor and getting worse. And there are many reasons for that we can examine. And the other part of what you raised, which is may have been raised yesterday, is the importance of compensating family-based care. In our society, in the United States, the vast amount of care is delivered by families, much larger than that delivered by the professions of care. But it goes uncompensated. Uncompensated financially, uncompensated in terms of status, uncompensated in terms of cognitive resources, which would mean that if you're a family that has routinely taken care of a patient with, let's say, diabetes, and you're using a treatment regimen that you know better than the primary care physician, you ought to have access to the pharmacy. You shouldn't have to go through a primary care physician. That's the transfer of cognitive resources. That's just important as financial resources. we haven't even begun to think of that yet. Well, let's get on to our next speaker. I didn't see, is Joya around here? Yeah, there you are, great. So now you're in for a treat, because my experience with Joya is that if there is a definition of charisma, it's Joya.
Oh no, that's a high bar. Thank you. Thank you, Dr. Kleiman. I feel very fortunate for the work of Dr. Kleiman and creating and supporting the Department of Global Health and Social Medicine for so long, and being one of the real pillars of that department, because it is my academic home. And I have to be honest, when I look around this room, I often feel a bit like an imposter in the academy. Because my main role is as Chief Medical Officer of Partners in Health, a very large non-governmental organization with 17,000 employees around the world, many of whom, the majority of whom, are community health workers. 11,000 of our employees are community health workers, are people who live in the community and care for their neighbors and their families. But I'm also still a clinician, and you know, some of this is actually outrages me. I have to be honest. And I'm super glad that my good friend Eric Sawyer is here, because, you know, each of the people that we're talking about are people who have families, who have lives. And I'm going to just take a minute to tell you about Marshall. Marshall was a 45-year-old man who was brought to the clinic that Partners in Health supports, a public facility, by community health workers and his family members on a homemade stretcher. Marshall was the father of 5 children and made his living as a motorcycle chauffeur, a taxi driver of a motorcycle. He had broken his leg and never thought that care would be available for him. When he started shivering and falling apart, essentially, his family contacted the community health workers and brought him into our very humble early days public facility that Partners in Health had worked hard with the government, and Kate Oswald and Lux and Dooley, some of my colleagues are here who are heavily involved in this kind of work. He had a very minor fracture of his tibia, but it was an open fracture. A piece of the bone was sticking out, and by the time we got him to care, he had gangrene, and it was more than 16 hours to the only hospital in the country that could do orthopedic surgery. And Marshall died. Marshall died of a broken leg. How can we, in the 21st century, think that is okay? And I think what worries me, and I've been very involved in the provision of care, in writing about access to care, in activism around care. I was at the UN General Assembly. I was at Astana. The face of the people who are suffering and dying is not being recognized. And I am very concerned that this is going to be a technocratic solution for real human lives. And we can say, well, maybe we in this room need to make a decision about whether Marshall should live or die, whether it is more efficient to give everyone ORS. But I can tell you, for Marshall, for his 5 children, and for his wife, it matters. It matters. And those are the very children that are going to need our support for the rest of their lives. That mother will live in poverty and is likely to have to trade sex for food, for protection, for her children. And it is in that milieu that we find ourselves arguing about health insurance, about financial coverage for some set of interventions. And I can tell you that repair of Marshall's broken leg is not in the set of interventions that was promoted at the UN General Assembly. And we ought to be outraged by that. I am just outraged by that. And so I made an intervention on the floor of the UN when the declaration for the first universal health coverage discussion was happening at the UNGA, talking about sets of intervention and primary care as the first step. And I said, what about people like Marshall? What about women who need a cesarean section, as I did? What about children who need neonatology, as my son did? And I was told, if you give them the choice, they will build tertiary care. And I said, who are they? And the person, a very distinguished person who, by the way, is in charge of billions of dollars, said, well, Africans. He said, I worked in Uganda. They wanted to spend all their money at the tertiary care. I said, with all due respect, Dr. So-and-so, I've been to Malago Hospital. It ain't no shiny city on the hill. The whole system is collapsing under the weight of inadequate resources. Primary care isn't an either or. I love primary care. I do lots of primary care, but I'll tell you, when I'm sitting in a primary care clinic with my colleagues in Haiti, in Malawi, we are often seeing 120 people a day. That's not primary care. It's essentially triage on the battlefield. The primary care as we know it in many places in the impoverished global south is a massive flow of need. And if we don't invest in systems of primary care, secondary care, tertiary care, medical schools, nursing schools, we're going to lose. And yes, we can save some lives with vaccination, with vitamin A, with oral rehydration, but I reject that that is what we should be doing in the 21st century. And we are so fortunate to have Eric Sawyer here. We are so fortunate to have been led by AIDS activists who said the right to longitudinal care is a basic right. It can't just be prevention. And so I'm going to talk a little bit about what I'm concerned about in terms of this interpretation of UHC. This is 19th century London. This is 1835 or thereabouts, okay? This is how people collected water in London. This is still how we collect water in places like Haiti, places like India, places like Malawi. Right? This is the places I know, many people are still like that. And we lionize Jon Snow for taking the handle off the pump. But for these mothers who are collecting water for their children, is Jon Snow a hero? Because he took the handle off the pump, but he didn't provide an alternative source of clean water. And that is the foundation of a lot of our discussions in global health. And I'm concerned about that. I love prevention. Again, I've given out more condoms than anyone who has an Indian father should. I mean, you know? But it doesn't mean that when I see a person with HIV, I don't want to treat them. And treat the social factors, the housing, which Eric has worked so hard on, the food security, which we're dealing constantly with in Malawi. When we looked at our work that Luxon leads, and Dr. Luxon Dooley, who's our executive director of Malawi, we had 6% of the children in Nano district had severe acute malnutrition. 6%. 6%. We can give them all the vitamin A they want. But if they don't get food, they will die. Malnutrition, severe acute malnutrition is a death sentence. So this is from the Astana Declaration, and we fought this. We fought this as partners in health. We are convinced that strengthening primary health care is the most inclusive, effective, and efficient approach to enhance people's physical and mental health, as well as social well-being. PHC is a cornerstone. Okay, it's a cornerstone, but it's not all there is. And we believe that primary health care must be linked to community participation. Community health workers alone cannot solve this problem, but they can be of great help if they are in a system of primary care, but that we also need surgery. We also need the treatment for severe schizophrenia. These are things that are eminently treatable in the 21st century. And when we look at massive inequalities, and instead what we are is bombarded with a bingo card of innovations. You know, I passed these out at one of my lectures and said, when you're at a health conference, you know, get your bingo. People talk about AI, web-based, leapfrog technology, tech-enabled drones, fabulous. But if you have no health system, they don't work. We use drones in Rwanda, and they work, because the health system is strong and we can bring in blood for a surgery with a drone. Cool. But a drone was not going to fix Marshall's leg. And so this kind of innovation, technocratic approach, if you will, is really lying about the fundamental problem, which is massive and systemic impoverishment that is based on the history of colonialism, slavery, racism, neoliberalism. And if we don't meet that head on, we will never get to health equity. This is the Rinkwavu Hospital in 2005, a hospital that I know well, a place I lived with my newborn son and helped to revitalize this. This was the district hospital for 350,000 people. This is actually the pharmacy. That's a pharmacy for a hospital. How can we not be outraged by that? Right? And do we do this without primary care? Of course not. You need clinics. You need people to get in the front door. But again, primary care is generally just urgent care. One of the things we're working on painstakingly is to have real primary care, longitudinal care where you actually track the person over time. And again, our HIV activist friends led the way in this. I am a person, right? I'm not a number. And, when you have HIV, you also may have tuberculosis. You also may have depression. You also may have heart disease. You don't come in because you have a disease. You come in because you're a human being looking for care. And then what happens is people blame the communities for not using these services. They said, well, the problem in Rwanda is demand creation, as if there are no sick people. But it's the supply. The supply of care is so poor. Even if you are the best doctor in the world, which arguably I'm not, but I did do my residency at the Mass General Hospital, so they probably would think that, man's greatest hospital and all. I can't provide good care there. Not only can't I don't want to. It's demoralizing. It's horrible. It's a sham that this is a hospital. So when we talk about the principles of UHC, which is, providing access to quality care for people without suffering financial hardship, we have to think about what is financial hardship. 800 million people, the UN says, spend at least 10% of their household budget on health care. They're not spending that on antihypertensives. They're not. Catastrophic expenditures are for things like Marshall had. They're for broken legs. They're for chronically ill patients who seek care por aquí, por allá, and move all over the place looking for care, expending huge amounts of money. This is where we see catastrophic expenditure. This is a family that we have cared for many years and continue to care for in Peru that had 5 cases of drug-resistant tuberculosis living in the bodies of these human beings. And they were seeking care. These people were seeking care all over Lima and couldn't get care. And people told us, well, it's too expensive to treat this. Stick with the set of interventions, and that set was DOTS, directly observed therapy short course, which does not treat drug-resistant TB. DOTS also doesn't include food. It doesn't include mental health support. It doesn't include screening for HIV, or it didn't for a long time. So the catastrophic nature of people's lives, and we know that the poor are the most likely to have catastrophic health expenditures. So when we talk about the insurance, the Minister of Health of Liberia told myself and Kate Oswald, look, we could have an insurance card today for everyone in Liberia, and it wouldn't mean anything, because we can't provide health care for them. So if we don't think of what catastrophic expenditure really means to a family like this family in Lima, catastrophic illness requires surgery, requires medicine, requires doctors. Again, I am not at all against primary care. But if a baby is born premature, if an infant has sepsis, they need neonatology. And that doesn't mean you still don't need to do antenatal care for the mother, have a good and safe delivery for the mother, have food packages and address the social determinants that could be domestic violence, gender inequality, lack of economic opportunity and education. But at the end of the day, you may still need a hospital. And so this idea that we're going to pick something, prioritize that as step one, we have been doing step one since the 1600s. And it is defined, our packages are defined in many ways by racism. And so when we look at the global burden of disease, like, let's be as scholarly as you're all smarter than I am, let's be as scholarly as these graphs will tell us. Cardiovascular disease is one of the biggest disease burdens everywhere. It's not only because of Oreos. I mean, I'm not criticizing the Oreos, but we have people with rheumatic valve disease who are in heart failure because they don't have access to penicillin. Yes, they need access to penicillin, but they also need their valve fixed, right? And if we can't do, these cancers, right? We have to be able to treat cancer. I have a living son who is a survivor of cancer at age 2.5, and it shouldn't be that he gets that because he's white. It shouldn't be, and because that's how it is in the US, by the way, right? It shouldn't be because he has a mother who's a physician, and he's a white kid, and he's cured at age 2.5, and I never even have to think about it again. That's just injustice. So I want to wrap up by saying 3 things. One is there is more money in the global south than we think, but it is structured in a way that does not provide health care. This is what a lot of the resource flows look like in the global south. There are many ministers of health that are my friends who are now using this graph because they agree with this. They go to vertical programs, often US NGOs, that don't pay government salaries, they don't compensate health workers, they believe on volunteerism for community health, and they're focused on one disease. If we can move this to real national health plans, we can find billions of dollars. And the idea that just this little domestic resource spending has to be used for sets of interventions is going to continue this cycle, where this money goes mostly into behavior change and IEC with the assumption that Black mothers are stupid, consultants like me who get paid 6 figures, and trainings, which are not the longitudinal mentorship and training I had the advantage of, but rather are trainings in capital cities where we burn money at the end of the quarter by paying out per diems to say we've trained X number of people. We reject that, and Mary Bassett, like many people, has really worked to change this with new programs that have training at medical schools, at nursing schools. The MEPI program, the NEPI program, these were from activists, physicians, and nurses and patients that said, no, we're rejecting this, right? We need to change that. And move that. So that's one source. If we do that, this is some of the work we've done in Lesotho, where we tried to rearrange. I see 2 minutes. I got it. I got you. I'm a fast-talking New Yorker. National health reform in Lesotho, all we did was this. We didn't really do anything different. We just tried to pay the staff, make sure that the supply chain was there. And what we did is the utilization of care in Lesotho with moving that needle toward a national plan resulted in massive increase in HIV enrollment, massive increase in vaccination, massive increase in facility-based delivery, because the health system worked. Not because we decided on a set of interventions, because we voted with our feet in the health system. We had 3 nurses that delivered their own babies at a health center for the first time ever. Community health centers were considered a place for poor people, not for professionals. And the community had a party for them. That level of solidarity, this is the care, my care is your care, not a different kind of care. We saw that we could massively improve the fill rate, again, just by shifting that arrow. Then the other thing is, how do you find something like TB? We have failed miserably, and I think TB is one of the main hallmarks of our failure, because TB has now eclipsed HIV as one of the main disease burdens of adults. Why? Because we've only focused on a strategy of prevention. We treat only smear-positive pulmonary drug-sensitive TB, essentially, and vertically. And frankly, people don't know what TB is. Most Americans don't know, well, we don't need to know because we have very little, but TB, we find TB when we invest in health systems. We don't find TB because we have campaigns about TB. We find TB when we invest in health systems and go out into the community and try to find the vulnerable. This is just our health system strengthening in Liberia, in that same clinic that Marshall died in. And just with strengthening of health systems, paying staff, putting in supply chain, renovation, those things, the TB case finding went through the roof. And we actually achieved universal coverage of TB case finding and treatment. So the second thing I want to say is every revolutionary struggle, these are revolutionaries in Africa who couldn't be here with us today, Kwame Nkrumah, Patrice Lumumba, Amilcar Cabral. They talked about equity and justice for their people and healthcare as a basic right. These are long-lasting struggles. And yet we know today that this is what Africa looks like. With $192 billion flowing out in illegal cash, corporate interest. We work in Kona, Liberia, which is home to the largest diamond mine in West Africa, and has the poorest people and the worst outcomes. It was also the epicenter of the civil war in Liberia. Why? Because of the diamonds. These resources are taxing people heavily, and they bear that tax as ill health, as short life expectancy. And the countries and the people themselves get nothing from it. And when you look at the revolutionary struggles in Africa, most of them were based on the notion of owning resources, on redistributing wealth, on basic social and economic rights. So in my opinion, we cannot win without a fight. And if we don't fight corporate power, neoliberalism, the racism that underlies our acceptance of distribution of resources, we're just never going to win. So I appreciate being here with you, but I hope some of you, and some of you already are fighters, but I hope more of you will join a fight.
Well, that's a motivating talk. Thank you, Joya. We might take a question or two for Joya, will you? We have a question or two? Yeah.
Thanks, Joya, for that really spirited defense of the right to health, which is what I take it as your overarching commitment. I just wanted to ask whether we use the word PHC and primary care sort of interchangeably.
Yeah.
And I think that your critique is mostly of the notion that all people need is primary care.
Yeah.
PHC, as conceived in Alma-Ata, included referrals.
Exactly.
And,
exactly.
and included the notion of a comprehensive
Yes.
health system rooted in a society that
Yes.
invested in the resources people need
And
to be
social
healthy.
determinants. Yeah.
Right.
I agree,
So,
Mary. Yeah.
can we just be careful about that? Because I think that's a lot in David's last paper. A big part of his point was that the Astana Declaration completely conflated PHC with primary care.
I absolutely agree. I absolutely agree with you. So, and we were, if we could go back to the Alma-Ata Declaration as a working document, we would be delighted. But it is this movement toward technocratic solutions and sets of interventions that are real. That's what's being promoted at UNGA, at Astana. Yeah, I'll send it around, so yes.
Let's take one other question. Another one? Yeah.
More questions for Refat.
So I'm looking at a document here that was produced by USAID right after Alma-Ata in 1979.
Mm-hmm.
And in it, they endorse
Yep.
the Alma-Ata Declaration and primary health care. And they say, this is what we're going to follow as our Africa strategy.
Mm-hmm.
And they say, we like primary health care because it's the most cost-effective solution, And then they say, the health problems and hazards claiming highest priority for US programmatic support are infectious and parasitic diseases, rapid population
Yeah,
growth,
yeah, I think we're
malnutrition.
familiar,
You know
yeah.
that one. And then, right after that, they say, well, there are some other problems that are less high priority. For example, Africans are also expressing increased concern over cancer, cardiovascular disease, and other chronic diseases that are becoming prevalent in the more developed sectors of the population and among the elderly. So, but those are not the high priority diseases for us. And so the
Yeah.
lesson that they took from Alma-Ata, from this Declaration on Primary Health Care, is that what they need to do is this first set of high priority diseases. So my question is about dialogue, the kind of discussion, the way that the discussion in health, people who are focused on delivering care, people who are focused on global health, the way that it gets filtered down through the centers of power. And what I take from this document is that the way in which the debate at Alma-Ata, which did have a component of liberation, but the way that it was assimilated, really they felt free to mention that they were interested in treating these prevalent
what's your
diseases,
question?
but they didn't. It wasn't necessary, and I'm wondering how to make the talk that you gave, this this powerful call for action on a comprehensive set of disorders, how to make it stick. What is the approach to making it stick? How can the more restrictive model be evaded?
I think we got it. Yeah.
I mean, we need action. I don't think there's any way to make things stick. We have to recognize where we are in the world and, keep fighting. It's not a one-step problem. I don't know.
Noya, can I add to Aaron's question?
Yeah.
Arthur, may I just for a second?
Please, sure.
Because our debate yesterday, I think the debate that kind of was framing us a little bit in the afternoon was the idea that we have to prioritize. And I think both Julia, Ole, and to some extent Sunanda and I had a discussion at dinner. We obviously have to prioritize. And so people are saying, well, you have to prioritize, and there are certain things that, yes, we may want to do, but we can't. And
I think,
and I hear you saying something different, so I'd love you to just
I mean, I think the idea of we, who is the we that has to prioritize? We sitting in this room at Harvard that are not faced.
So the
No, I
model
know.
presented
This
was-
is my answer. This is my answer. This is my answer. This is my answer. Okay. Who is the we? So we're told all the time we need to prioritize. Who's the we? It's not Marshall, right? Marshall's not being asked to prioritize. And I can tell you by and large, it's not the ministers of health either. It's the ministers of finance who are under neoliberal policy constraints, who are trying to push back, who are getting sued. For example, when the government of Ghana was sued by Glaxo for trying to import antiretrovirals, right? Who are under a set of constraints that have been created here, right? So when we say this we part, who's the we? Right? I have never talked to a minister of health that doesn't want a more expansive view. And they're not saying we don't want PHC, we only want, fancy hospitals. There are very few fancy hospitals in any of the countries I work. The fancy hospitals are crap, right? So we need more money. But we have no problem with, trillions of dollars going into the militaries. And, interestingly, structural adjustment never touched military budgets, right? So we need to really rethink what human rights looks like in the 21st century. And I know I'm not as, but yes.
No, that's terrific. Yeah, precisely. Well, we're going to see one of the real issues now. We're going to turn to commercialization. And it's my pleasure to invite Rama Baru up to lead us through this.
Thank you very much, Salman, Dr. Scott, and his colleagues for inviting me. And it's an issue that was very close to my heart, so I decided to fly from Delhi to Harvard because I teach social medicine, which is located in the School of Social Sciences at the Jawaharlal Nehru University, a rather unusual combination. I want to just preface, I'm going to read from my paper, but I just want to say that yesterday's discussions were very rich, but they were also very disturbing and disconcerting for me. And I think, except for a few scholars yesterday who, I think the discussants who raised the question of histories and context, I think those are very important when we are looking at the issue of universal health care and health coverage. Because I do believe histories, ideologies, and the market have reshaped ideas of what is the technocentric solutions to many of the health problems. And also, if you like, the social determinants of health, which has not been discussed very much, Marmot's report, actually, in a sense, revisited and critiqued a technocentric approach to health. And I liked what Joy said very much today, which is a longitudinal care approach, and then Dr. Kleinman also alluded to it. So with these few words, I just want to read my text of my paper. I've titled my presentation as Commercialization of Health Systems and the Subversion of Universal Health Care. And I use these words very carefully, and as the paper spans out, it may make it more clear. The concept of universal health care and coverage are often used interchangeably in the global health discourse. As a result, there is a lack of conceptual clarity and recognition of the fact that the two concepts have different historical and ideological roots. The former can be traced to the idea of social medicine of the early part of the 20th century in Western Europe. The latter is the product of the growing commercialization of healthcare and the need for governments to provide an insurance cover to needy consumers of increasingly expensively provided care. The core values of social medicine were universality, equity, and comprehensiveness that required state-funded public health services for realizing universal health care. There was a broad ideological consensus on the idea and practice of social medicine, ranging from the paternalists to the Marxists. Several European countries invested in public health services during the interwar and post-Second World War period, and we saw a lot of that data in the earlier presentation this morning. And the concept of social medicine that dominated the imagination of public health theory and practice during this period found wide recognition in both Western Europe and the United States. Prominent physicians who subscribed to this perspective and actively advocated the idea of social medicine included Henry Sigrist, John Ryle, John Grant, Russell, Newman, and Gunn. Gunn wasn't a physician, to name a few, formed an epistemic community of doctors and social scientists advocating these ideas. They were associated with institutions that included the International Health Division of the Rockefeller Foundation, the Johns Hopkins Universities, and others who were actively engaged with China, India, and several Latin American countries. They contributed significantly to the debates on how to structure and organize health services in both developed and developing countries. As Romer observes, that there were debates around the importance of the integration between preventive and curative medicine that shaped the idea of health centers at the primary level of care. These ideas found their way in the government policy in the report of Robert Dawson, which was constituted in 1920, which stated that, and I quote, "Preventive and curative medicine cannot be separated on any sound principle, and in any scheme of medical service must be brought together in close coordination. They must likewise be brought within the sphere of the general practitioner, whose duty should embrace the work of communal as well as individual medicine." The Dawson Committee recommended a graded referral system where complex cases would be referred to secondary health centers, which would be staffed with specialist consultants and closely linked to hospitals. In fact, similar ideas were also suggested and legislated by the Health Commissioner in New York in 1920. The legislation came to be known as Sage-McCall Bill. However, in the US, these ideas were immediately opposed by the State Medical Society, which testified at hearings that doctors and I quote, fear it would prove harmful to the medical profession and that it meant the establishment of state medicine. As a result, the Sage-McCall Bill was not implemented in New York and became a symbol of both an opportunity and of resistance to it in the evolution of the idea of social medicine in the United States. The practice of social medicine gained visibility with the post-war experience of the Soviet Union and China. Henry Sigerist's work on Soviet medicine and John Grant's on organizing health services in pre-revolutionary China influenced the theory and practice of social medicine globally during this period. Sigerist was more of a socialist in his thinking than John Grant, but in terms of the practice of social medicine, they were in broad agreement. The work done by John Grant in China as a part of the Rockefeller Foundation's intervention in healthcare laid the foundation for the development of public health at the Beijing Union Medical College for training public health professionals. And he also initiated several pilot projects for creation of health stations where he actually, in a sense, worked with this idea of primary, secondary, and tertiary as an integrated, comprehensive approach. Grant subscribed to the view that public health was an integral part of the socioeconomic development of society and therefore emphasized the need for integration of preventive and curative services, with the state playing a central role in financing and provisioning of health care. Grant's role as a leader of the International Health Division of the Rockefeller Foundation in China provided his ample evidence to translate his learning to other countries like India. Even as early as 1928, in his address to the annual conference of the China National Medical Association, Grant favored the idea that healthcare ought to be assured to all through a state-administered machinery. With the establishment of the People's Republic in 1949, Grant was no longer actively associated with policy in China, nor could he exercise any policy influence. But generations of his students and colleagues whom he had interacted with occupied influential positions in the Chinese government. Thus, the idea of social medicine found its place within a socialist state. After his involvement with China, John Grant was deputed by the Rockefeller Foundation to set up the All India Institute of Hygiene and Public Health in Calcutta in early 1928. It is his presence in India as part of the International Health Division that allowed him to participate in the deliberations of the Bhore Committee report, and Grant was formally invited by the Bhore Committee as an international advisor. The Bhore Committee report also influenced thinking on healthcare in several post-colonial societies in both Africa and Asia, drawing attention to the role of social medicine in the development of public health services. The historical inequalities imposed by colonialism and the politics of post-colonial societies impacted health service development and underlined the importance of public institutions as a necessary foundation of universal health care in these societies. Therefore, the experience of universal health care in low-middle-income countries and low-income countries cannot be compared or conflated to the high-income ones. The Alma-Ata Declaration of 1978 was an important moment in the history of public health that resurrected, in my view, the idea of social medicine. And in fact, Aaron, when you spoke about the double truth, I have always been grappling with this even as I teach Alma-Ata to my students. But I want to say that it still remains an important document for the South because it gives us an imagination of how to coalesce and move forward to fight for the rights that we have been hearing, whether it is by Dr. Ray or Dr. Mary or even Joy's presentation and what we heard from the HIV/AIDS. I think it was an inspiration in terms of the principles, the idea of social justice, the idea of comprehensiveness. So I think it was a very important document in history. This was in part due to the global failure of disease control programs that had become far too dependent on technology and technocentric solutions. I here disagree with Julia Walsh, who in a sense really is an advocate for the technocentric approach. Yes, we have had good health improvements, but I think we need to re-examine whether it was only due to the disease control programs. It was also enabled by an alliance of progressive movements in the developed and developing countries and the growth of community health projects led by civil society organizations. These taken together once again revived interest in the primary healthcare approach. The unraveling of the Alma-Ata Declaration began within less than a decade with the assertion of neoliberal ideologies that contributed to growing commercialization, liberalization, and globalization of the economy and of policy in the social sectors. The rapid growth of commercialization altered the terms of discourse, redefining the public in public health. The public was now the consumer, no longer the community. The growing power of markets reshaped how institutions think and behave. This is both the public and the private, the way it worked. It influenced medical and health practitioners and also altered perceptions of users. There was growing reliance on technology, medicines, and hospitals for health problems. In the 3 decades since the 1980s, there has been a fundamental change in the thinking on the role of public institutions in health services. Big capital that was financing not just health provisioning, but also pharmaceuticals manufacturing, health technology, education and research, increasingly, in my view, assumed the stewardship of healthcare and policy. And this is not just a national phenomena, it is a global phenomena, and the partnerships and the interconnections between the global and national capital. In developing countries, the nexus between global and national capital produced complex network of actors, and their power to influence national policies increased significantly. The concept of commercialization helps us examine the growth of markets and its influence on public health systems, medical practice, and policy. The history and the extent of commercialization of the health system varies across countries. Many European and East Asian nations invested in public systems, while most post-colonial societies in the developing world, especially in South Asia, underinvested in health, owing both to competing social and economic demands in the government and the limited fiscal space available to government in a backward economy. While several African and Asian governments subscribed to the idea of universal healthcare, they did not have the institutional and financial wherewithal to realize this aspiration. This resulted in a weak public system for provisioning and dependence on multinational companies for investment in pharmaceuticals and medical technology. The process of commercialization was furthered in the 1980s with globalization and liberalization. I didn't hear too much about the health sector reform of the 1990s, which enlarged the space for the market in both public and non-profit sectors. As a result, commercial interests, global, national, and an alliance of the two came to stay in all the subsystems of the national health system. One consequence of the commercialization of the health system was the increased focus on financing and provisioning of curative services. This has undermined the principle of comprehensiveness and equity in the idea of universal healthcare. In many low, middle, and low income countries, a dual system of private and public has come to stay. The idea of equity is no longer defined in terms of social solidarity and community-based approaches, but instead has come to be defined as targeted public insurance schemes meant for the poor and aimed at financing hospital care. In many countries, a weak primary level of care resulted in large out-of-pocket payments for outpatient and as well as inpatient care. This was antithetical to the idea of comprehensiveness as defined in the Alma-Ata Declaration. In this era of rampant commercialization, the idea of universal health care has been subverted and has come to mean universal health coverage, allowing care to be passed off as coverage. The idea that fundamental human rights, social and redistributive justice are core values that define the concept of universal health care is actually antithetical to the idea of health as a commercially provided service. The commercialization of healthcare in poor societies has required governments to introduce the concept of universal health coverage. It's a heady mix of populist politics and the SOPs that the public subsidies can be given to the private market. It is a continuum and a corrective to the health sector reform that pushed for commercialization and privatization of health services across the globe. Country experiences of implementing universal health coverage show that it's restricted mainly to public insurance schemes with mixed provisioning. Where there is a strong history of public provisioning, it's easier to regulate and control the behavior of the private sector. In several lower middle income countries where there's a large and diverse private sector, the ability of the state to regulate is very limited. This is due to the nexus between private interests, medical practitioners, the political class at local, national, and global levels. In such contexts, the private sector is able to shape policies to their advantage and wrest public subsidies that are essential for maintaining their profit margins. Many middle-income countries that have a near universal coverage through social insurance schemes are also trying to rationalize rising costs in several ways. There is an effort to redefine the scope, breadth, and height of coverage. In order to reduce hospitalization rates, there's an effort to strengthen now primary level care to act as a gatekeeper to secondary and tertiary levels. China has been trying various means to contain costs by investing in some regions in primary level care. The once weak community health centers have expanded to provide a range of preventive, curative, and promotive services. The investments made are in human resources and community-based supportive services that provide integrated care. This is extremely patchy, and I think there is a lot of discussion around how much and what is to be done. Such investments are not forthcoming in many low middle income countries like India. The required financial and human resources and institutional arrangements do not match the hype and hope of universal coverage. And certainly, we are very, very far away from the idea of universal health care. Thank you very much.
Just stay there. We'll take one or two questions. Come up here. We'll take one or two questions. Yeah. How about for Professor Baru? Question or two. Vikram.
Thank you, Rama. As we have often worked together in India, one of the questions I had for you was about the issue of power in the Indian framework, in particular, the very interesting coexistence of community mobilization, for example, within the National Health Mission to hold healthcare accountable, the coexistence of a traditional system of medicine that has now been formalized, and the very powerful position of biomedical practice.
I think it's a great question, and I think it is to do with some level of leverage of democratic politics. Because like in Africa, I think the People's Health Movement, I'm not just talking about the Jan Swasthya Abhiyan, but I think the civil society groups that have sort of worked at the grassroots level were very, very important in their representation during that period, which is the period when the Congress-led government was in power. And when the idea of the National Rural Health Mission came up, it came up with a lot of pressure from below, saying that and in fact, the constant reference was to the Alma-Ata Declaration. So a lot of the best practices and the experiences of various groups, and they were not all, they were ideologically quite plural, but who had this deep concern for the welfare of the person and, the kind of values that were espoused. It was in a sense, so you had the community mobilization, you had a very strong civil society engagement, but at the same time, you had the power of the private sector. So the public-private partnership came in a particular way at secondary level. And you also had a government, don't forget, was a coalition government, where you had the representation of the left and the middle, what was the middle party of the Congress. So if you like, the nature of democratic politics through this rather, unusual combination of things. But I think each of the communities involved in the representation of the interests of the people found some space, but it was also a frustrated space, that you could push the government so far, but beyond that you couldn't push it further. So I think it was a very interesting point in history, but that history is now, it's history.
Okay. We'll take one more question. Yes, over here.
It's this Julia Welsh. It's more kind of a comment. That I agree with you. The commercialization of health systems has can be very detrimental. We're sitting next to the Sackler Building, which is that's a family name that's notorious in the United States for having pushed opioids and led to tens of thousands of opioid overdoses from excessive prescription by physicians. But so that's one kind of very negative effect of the commercialization of health systems. But we also have in examples of how vaccine manufacturers have been involved in many of the child survival efforts, public-private Gavi currently, and then in developing relatively low-cost new vaccines that I think have led to the prevention and averted many deaths from by widespread use in children.
Okay. Do you want to respond to that?
No, that was just a
Okay.
comment.
I just wondering, before we take it, we're going to take a break now instead of taking it later. David Jones, you're working on cardiology in India, you've worked on. You have any response on this?
No, it's an interesting problem. I hesitate to say anything with a real expert here at the front of the room. But you see the tension in India that you've seen in many countries, and Joya showed some of this. There's a desire to have all services available, because if someone has rheumatic heart disease and the technology exists, why shouldn't that person have access to getting their rheumatic valve fixed or replaced? But the question is just, how do you do that with all the competing demands on these systems? And what you see in a place like India is they had developed sophisticated cardiac capacity at a very small number of private or missionary hospitals in the 1950s and 1960s. And it was trickling along slowly, and then totally explodes in the 1980s and 1990s with the commercialization of the private sector. And now you have likely the best cardiac surgeons working in the world are probably either in India or in China, because their surgical volumes are so much higher than the surgeons anyplace else, but it's entirely in the private sector. And so you have this weird situation where you have stupendously skilled providers providing services to a very small number of their own citizens or to people who travel to those places for care.
Yeah.
It's a very difficult problem.
You're going to respond to this on this one? Yeah.
Yeah, thanks very much. Because the situation now, I suppose it's called globalization or medical tourism or whatever it is that people from Africa or from Southern Africa anyway, I'm not so clear about West Africa, but they're actually traveling to India to have these procedures. And sometimes that's paid for by medical insurance that's employer-based and the constant argument is why do we not develop those private sector facilities ourselves? And it's based on cost that India, I don't know about China, but India can provide it cheaper than anyone else, but because your labor costs, I believe, are much lower. And also in a situation, Zimbabwe, Malawi, Mozambique, wherever, is that you have the surgeons are trying to make their profits from a very small base of customers. And so their costs per case are much higher. And I think the reality is, I don't know how to resolve that situation. I really don't. But the thing is that if you take a place like Botswana with a population of 2 million people, it's unrealistic for them to try and provide everything within the country, to try and train surgeons to that level. If you want to have cardiac surgery, maybe not valves, but more extensive cardiac surgery, you want someone who's doing high volumes. You don't want someone who does one case a week. So maybe we're moving towards that in the private sector, that there will be centers, at present South Africa, I suppose, who provide that. And then the issue is who pays for it? Who pays for the training as well as who pays for the facility?
Yeah.
And we're subsidizing it. That's my point. I really think we have to sort this out because the middle classes want those. And the market will say if they have the money, they should be able to do it. But then the cost should include the total cost. It shouldn't be subsidized by the public sector for the training and then be provided at a particular cost.
You want to respond?
Yeah. In fact, in India, it's an interesting phenomena of public insurance and private provisioning. So it's the public sector that is actually paying for even the poor to access the private hospitals. And for the private hospitals, that public subsidy is very important because you're assured volumes. You cannot run a private hospital and make your profits if you only rely on the middle class and the rich. The numbers just don't add up. So in a sense, my argument, especially for the states that have led the public health insurance schemes, they are the states where there was a very large private sector. And the private sector influenced the state governments to, in fact, institute public insurance schemes. So it is the Prahlad kind of argument, the race to the bottom of the pyramid, where you need to tap that 40% that is out of, being able to access. It's not just health, it is also a range of other products in the market. They just don't have the capacity to buy. So you cannot have them even access these services. So in a sense, the private sectors demand on the state and the ability to influence the state to actually come in with a program whereby the poor then access these corporate hospitals. And the entire perception of people of what is good medical care has been transformed through this process.
Yeah. I wonder, actually, in this regard, let me ask you to respond to an example. Bhrigupati Singh at Brown and Andy McDowell from Harvard, amongst others, have researched village care in Rajasthan. Mm-hmm. And in Rajasthan, almost all village care is being delivered by what are called as Bengali doctors.
Yes, Bengali.
The Bengali doctors are businessmen from the south who come up to Rajasthan, are trained very quickly by drug representatives, but they provide the only village-based access, let's say, to antibiotics. But they have minimal training and they often make mistakes. So what's your sense there? They are, in fact, providing the medicines.
They are the primary level practitioners.
Yeah.
In many parts of the country.
But they are there to make money.
They are there to make money, but they're also the only ones available for care.
Yeah. Okay, well, let's take our break now, and we'll be back. How long do we have, Salman, for the break? Okay. You can interpret that loosely, since we're interpreting everything else loosely here. Well, we're now moving ahead to the last presentation before our discussant of the morning, and we're privileged to have Socrates Litsoisis give a talk on how primary health care got lost in translation. Please.
Thank you. Well, I want to thank the organizers for inviting me to this conference. I hadn't realized how much pleasure there would also be in visiting the Harvard in the area. My wife and I lived here the first 7 years of our marriage. So simply walking around, I relived many of those moments with great pleasure. But I must admit, for this conference, I feel like a fossil. And I think if you look at my CV, you can understand why. I mean, electrical engineering, operational research, and then by some miracle, into primary health care. And I can remember the moment, not the day, but the moment in early 1974, and I don't remember what provoked this thought, when I remembered that just before I joined WHO, I was in Washington, D.C., and I was chairman of a local education committee. Our role was to try to improve the system of education in the District of Columbia by meeting and looking at our school and comparing our school to the other schools. We lived in an area. When we learned that our school was the average school in Washington, we ended up having some people say, well, if we have one pencil less than the other schools, we should demand that pencil. Anyhow, in 1974, my mind went back to that, and I realized participation is an important business, right? And that became part of, not part, it was already there in my understanding of what we should be doing, even if I knew nothing about health and what have you. So, how primary health care got. When I joined WHO in 1967 as a member of the Division of Research in Epidemiology and Communication Science, the malaria eradication program was the organization's top priority. With the collapse of that program in 1969, WHO turned its attention to how best help countries develop their health services, a task that Kenneth Newell, director of WHO's Division of Strengthening of Health Services, was given. Newell had been the director of Research in Epidemiology and Communication Science Division, a division that Halfdan Mahler, soon to be WHO's Director General, disbanded in 1972. I couldn't resist incorporating this picture of me in my presentation. It was taken in 1973, shortly after I learned that I still had a job with WHO after having been fired by Mahler earlier that year. But that's another story. So I was a member of the team that Newell had formed to prepare a paper on primary health care for the January 1975 session of the Executive Board. And these were the principles that we introduced, shaped around the life patterns of the population, involvement of the local population, maximum reliance on available community resources while remaining within cost limitations, integrated approach of preventive, curative, and promotive services for both the community and the individual, all interventions to be undertaken at the most peripheral, practicable level of the health services by the health worker most simply trained for this activity, other echelons of the services to be designed in support of the needs of the peripheral level, and PHC services to be fully integrated with the services of the other sectors involved in community development. In a paper prepared in 1976, Mahler presented this definition of primary health care, one which I believe captures more elegantly the original 7 principles. A health approach which integrates at the community level all the elements necessary to make an impact upon the health status of the people. While the development of primary health care was likely to be unique in each country, recurrent features were seen in successful examples. The use of health workers resident in each community, a clearer link between the health worker at the peripheral level and other aspects of community development, the importance of the involvement of all members of the health system in its development, and active involvement of the community and maximum and flexible utilization of existing resources. WHO's promotion of primary health care led the Soviet Union to campaign for the holding of an international conference. This took place in September 1978 at Alma-Ata. As I've described in my paper, The Long and Difficult Road to Alma-Ata, Personal Reflection, there was considerable differences of opinion inside and outside the organization as to what exactly was meant by the words primary health care. Despite these differences, the declaration of Alma-Ata remained more or less faithful to the 1975 definition. I'll let you read that to save my throat a little bit. Primary health care was identified as the key to attaining a level of health for all that would permit people to lead a socially and economically productive life. The Alma-Ata Declaration went on to identify specific elements that primary health care would include, elements that were not identified in 1975. And here are the elements: education concerning prevailing health problems and the methods of preventing and controlling them, promotion of food supply and proper nutrition, an adequate supply of safe water and basic sanitation, maternal and child health care, including family planning, immunization against the major infectious diseases, prevention and control of locally endemic diseases, appropriate treatment of common diseases and injuries, and provision of essential drugs. No program wanted to be left out. At Alma-Ata, the WHO's director of mental health was successful in getting mental health included in the recommendations that were adopted by the working committee at Alma-Ata, but mental health was subsequently removed by WHO senior management, so it was not incorporated in the declaration. Thus, Alma-Ata itself was already the beginning of primary health care being lost in translation. More importantly, by defining primary health care in terms of its components, Alma-Ata left primary health care open to the criticism that it could not be afforded. Of more immediate importance, however, was UNICEF, a co-sponsor of the Alma-Ata conference, backing away from its commitment to primary health care by joining those voices that argued that Alma-Ata goal of health for all was unrealistic. Instead, it adopted a new strategy in 1982, one designed to achieve a child survival revolution through 4 basic interventions: growth monitoring, oral rehydration therapy, breastfeeding, and immunization, the GOBI approach. One critic claimed that UNICEF's new strategy replaced participation with compliance, as depicted in this slide. Much more critical is this cartoon, which suggested how UNICEF's nutrition advice avoided looking at important underlying causes of poverty and inequity. I'll let you look at that for a while. It's a very rich cartoon. Mahler's reaction to this, to UNICEF's new policy: "I'm all for impatience if it leads to better and speedier action along collectively agreed lines, but I'm all against it if it imposes fragmented action from above. I'm referring to such initiatives as selection by people outside the developing countries of a few isolated elements of primary health care for implementation in these countries, or the parachuting of foreign agents into those countries to immunize them from above, or the concentration on only one aspect of diarrheal disease control without thought for the others. Initiatives such as these are red herrings that can only divert us from the track that will lead us to our goal." The debt crisis and recession in the 1980s pushed primary health care into the background while increasing the attractiveness of UNICEF's selective approach to child health. These crises no doubt contributed to many PHC advocates expressing their concern about its prospects. There's a list of some of the literature that came out in the 1980s. I'll let you have a little time to look at that. Maybe you're familiar with some of these articles. But it was an intense period, the 1980s, where social scientists, academics were really looking at the prospects of primary health care and offering their advice. Newell rightly pointed out that selective primary health care could possibly have started from the lists of Alma-Ata. To the convinced PHC advocates, selective primary health care proposals are not PHC at all, but the antithesis of it. They are disease control programs which are ideologically similar to the malaria eradication disaster. Several authors were highly critical of user financing and cost recovery schemes that UNICEF in particular was advocating. As David Werner noted, just because poor families are willing to pay for medicines does not mean that they are able to pay for them. Mahler's successors, Nakajima and Gro Harlem Brundtland, had other priorities than that of primary health care to pursue. Only when Margaret Chan took over the leadership in 2007 was primary health care renewed. In her annual report for 2007, Chan justified the renewal of PHC as a response to globalization, which was putting social cohesion of many countries under stress. And health systems were clearly not performing as well as they could and as they should. Under her leadership, a series of meetings were organized in 2007, which led to the World Health Report for 2008, Primary Health Care Now more than ever. This important publication is 118 pages long and rich with analyses. This slide, for example, is a useful account of how the focus of the PHC movement had changed over the last decades. However, if one examines this history carefully, one sees that what is being portrayed is not a history of primary health care, as it was introduced in the 1970s, but a history of primary care. Similarly, this diagram is about primary care, not primary health care concept and principles, as is this one. If we look at the table of contents of that report, we learned that of a new goal, namely that of advancing and sustaining universal coverage had been introduced. At this point, I must admit a personal bias against the expression of health coverage, despite its laudable aims. This stems back to July 1975, when I had the privilege of introducing the 7 principles of primary health care to the Christian Medical Commission's annual meeting. On that occasion, I expressed the importance of choosing the right words to express an idea and contrasted the goal of helping people help themselves, which is the title of a paper that Newell had recently published, with that of increasing coverage of the health services. There was life and hope in one, the other sounds more like the same. My reaction today is more or less the same when I see how universal health coverage is defined. It means that all people have access to the health services. I will not read it all, but just paraphrase it. To make health for all a reality, we need individuals, communities who have access to high-quality health services so they take care of their own health and the health of their families. Skilled health workers, people-centered care, and the policymakers committed to investing in universal health coverage. Universal health coverage should be based on strong, people-centered primary health care. Good health systems are rooted in the communities they serve. They focus not only on preventing and treating disease and illness, but also on helping to improve well-being and quality of life. Although the words primary health care are used, they clearly refer more to primary care services. As implied by the word coverage, this definition is a view from above, whereas Newell's primary health care, as reflected in the principles outlined in January 75 and his publication, Health by the People, is from below. Thank you very much.
Just stay here and take some questions. Okay. Well, I thought if you've read the paper and you've listened carefully to this, I think this really is a good example of the title, of it getting lost in translation. And so let's have a few responses, questions. This is the postprandial period of sleeping. Please wake up and let's, yeah.
Thank you, Dr. Litzius, for just such an amazing talk. I just want to reflect, just to relate this to the previous talks that we've had. Joya made a comment in her discussion that if we could only go back to Alma-Ata, that would be great, because we've even diverged from that. And I think you're looking, you're differing from the conversations yesterday, which were that the selective primary health care movement was a major diversion, obviously from Alma-Ata, and you're saying that even Alma-Ata to some extent was watered down from what people really wanted.
Well, the thing is, Alma-Ata, of course, is known. The report is there. The 1975 our statement on primary health care, that's not to be found. It's only to be found in the publications
so my
of WHO.
question to you is that what's your view on this, what's happening now? Because now we're moving towards advocating a minimum package that would be covered through insurance that's sold. So we've heard this morning, there are certain risks using the private market as the distributor of social goods. and on top of that, we are advocating a minimal package that would be distributed.
Well,
And that seems completely antithetical to what you've just presented.
I'm really not in a position to answer that kind of question because my research over the last, since I retired from WHO, has not been on primary health care. It's been on other aspects of health history. My gut reaction is, like other people have reacted negatively to what's happening today, I would agree with them. We applauded this morning in one of the talks. I joined the applauding. But I haven't really studied that carefully enough to come up with my personal opinion.
Right. That demurrer is wonderful. We almost never hear that from academics. Other responses, questions? Yes, please. Yeah.
Thank you. First of all, thank you, Socrates, for this talk, and not only for this talk, also for all the work you are doing on the history of Alma-Ata and primary healthcare, which I think we all privilege very much of your insights and your approach and the knowledge you share with us. I find it fascinating what you are telling, but I will go to some and also to the general issue of this conference of rethinking or reconsidering Alma-Ata, and think it's not only about going back, but you have shown how the history changes also in this very time of the 70s. And I think it's not only going back and rereading, we have to reread the historical documents and much more than we are used to do, I think, not only Alma-Ata Declaration, but also other publications from WHO and later, and all what you showed from the 80s, all this interesting discussion about what happened to Alma-Ata is really important for us to rethink what was happening and what this means to us. But then I think also we have to translate this historical knowledge and ideas and discussions to our current times and think what happened since in the last 4 decades. And I think there are a few things happening which are, in my opinion, very important. First of all, we are not in the 70s anymore, but there was a history of, for example, of HIV/AIDS, which has shown really what social movements can achieve. And they also had a strong impact on the history of the human right to health. And while in Alma-Ata the idea of the health as a human right was very vague still, now we have all the work done on international law that we know much better what the human right to health means. We have instruments like AAAQ criteria and so on. We have the general comment from 2000 where Audrey was involved in preparing. So we know much better today than 40 years ago what the human right to health means. So we can apply this and do this practically. And we also have the history of neoliberalism. We have the history of commercialization. So we really have to reflect on what this means for Alma-Ata. So we should not be naive and go only back, but really think what the political development was since then. And then we have now also another topic, which is I'm from Germany. We are working very much on migration, and we see it's not only an issue that inequities and racism, this kind of thing, is not only an issue of low developed countries, but even in wealthy countries. We don't have universal health coverage. We exclude migrants. We exclude a large part of our population, and that's in wealthy democracies. And that's things I think that in the 70s nobody could imagine that would be happening. That when we have wealthy countries with democracies, with strong health systems, and still we exclude them from universal access to health, and not only to health care, but also to the determinants of health. That's also a very strong point to consider today, I think, in this difference of the past. And my last point would be that we used to forget that Alma-Ata was also kind of reflection about medical education and the health professionals and so on. It was a strong critique on the medicalization of health, and Mahler said, for example, one of the problems that we have ministries of health that are not ministries of health, but ministries of medicine. So only thinking in medicine and not in the broad idea of health. And I think we have to invest in education. The medical students, public health students, but probably also have a voice in society to stress that medicine is not a technical issue only, but we have this broader, comprehensive view, and I think there are 2 main points for education, and then I will finish. One is what you said, Dr. Kleiman, is actually the issue of care, that we have to highlight the notion of care much more in education and also the political dimension. And before we have been talking about the social determinants of health, but there's now also the new notion. I find it interesting to relate the social to the political dimension and talk about political determinants of health, because the social inequities are a result of political choice. So to talk more about political determinants of health and to bring this into the discussion. And that would be kind of, for me, kind of a program for reconsidering Alma-Ata, but relating this to the challenges we have today and to the historical experience of the last 4 decades.
Thank you for that. Yes, please. Yes, well, I think more fundamental is the question of the role of medical doctors in all of this. Mahler was critical of the medical profession. So was Newell. I've studied the history of medical education extensively, going back to the early 1900s. It's not to say medical doctors are the enemy of primary health care, but they are certainly not the proponents of it. They are not, generally, they're not on the front line. Not front line is too strong an expectation, but they are not trained. I mean, I talked to my doctor, and he agrees that that's very important, but he says, who has time for that? Right? He's in his office, people are coming, and he treats them, and I'm happy that he's a good doctor. But what else can I ask of him? The links between medical schools and public health schools. Public health schools ended up becoming research-oriented. Right? Their responsibility in the promotion of health services and the training of health workers, it's hardly found. And it's found, of course, in some countries. You go to Stampar, Yugoslavia in the 1930s, you see that there. And maybe post-World War I, World War II, you find other countries doing that. But basically, you have the public health schools that are stuck in a research model, and you have medical schools that are training doctors to provide medical care. There's an enormous void in between, and I don't think social determinants of health is going to approach that. Social determinants of health will simply go back to all the underlying factors that we all know are important for health, and we'll get, improved nutrition, and maybe even radical things like land reform or whatever, but governments aren't going to act on that. Sorry.
Well, I mean, with that sobering thought, thank you very much.
Thank you.
So let me now invite Dr. Yates up to comment.
Great, thank you very much indeed. And what an amazing set of presentations, and very, very different in styles, particularly between the first two. It was wonderful. Now, I actually only saw a couple of those presentations for the first thing this morning, so I sort of, in terms of my respondent comments, have been doing it on the hoof somewhat. But I think that one thing that alarmed me a bit when asked to talk about this session, sort of universal health coverage or universal health care, was thinking, oh no, is this going to turn into one of these really turgid debates about terminology? And, we are masters of this at health. Is it primary health care, primary health services, primary health? Is it NCDs, NTDs, AMR? It's just a cocktail of acronyms. And I think there is a bit of a worry sometimes that we're masters at sort of trying to think about health and the health sector and cut the cake up lots of different ways and analyze it in lots of different ways, which may sort of generate lots of papers and interest, but, the rest of the world just finds, stunningly tedious and boring, to be honest. And I really, really enjoyed the presentation yesterday by Daniel Allen, when she basically said to us, you lot need to get out more. You really do need to engage with the rest of the world in putting forward your case better, because we have got obviously a tremendous case to be made, and that we intrinsically know that people value health and health services, and despite what was sort of inferred yesterday about sort of people not being altruistic and not caring for one another. I think we do, and there is this absolute obvious need to sort of move to a sort of a health system where everyone gets the health services they need. I was just wondering, could you maybe bring up the last slide from the previous presentation, please, Socrates' presentation, because I would like to sort of discuss a bit, the terminology. I don't want to get too hooked up on sort of definitions of universal healthcare and universal coverage, but I think it is important to sort of recognise that the global health agenda is being driven by universal health coverage at the moment. 3 weeks ago at the United Nations, head of state after head of state stood up there, Modi, Kenyatta, all these sort of heads of state were there saying that this is what they intended to do. And this is the sort of the front line at the moment. And, this is a battle I'm going to suggest worth fighting for. Now, what we need to make sure, and I think it's very interesting looking at the history, and it's been an absolutely amazing education for me, is to see how health for all, primary health care, we lost the plot. We didn't succeed, and sort of that strategically we may have been too conservative. We may have sort of far too easily rolled over and become more selective and bought the line that we can't be more ambitious. And it's absolutely vital that we don't do that again with universal health coverage. Because I think that universal health coverage, if you go back to that top definition, and that's sort of quite wordy, but you sort of get the idea there are 3 parts to it. First of all, the universality. Everyone on the planet, migrants, refugees, everyone should get this stuff. And so, it's unacceptable to exclude populations because they're migrants or refugees. And that goes for my own country as well, which is introducing upfront NHS charges for refugees and migrants, which is fundamentally wrong. And thankfully, there are people campaigning very strongly against that now. The next aspect is that services, and we can talk about, is this really about services, and that we need all those other determinants of health. And I do accept that that it doesn't really address other causal factors of health and social determinants of health. And we need to sort of think more imaginatively about how we bring this into this agenda. But in saying that, let's face it, that so many of the things that we're talking about here, be it sort of TB or other issues, is around people getting services. And if we are sort of imaginative with this sort of thinking about promotion and prevention, which would include things like sort of ensuring that there's clean air to prevent, lung diseases and things like that, that, you can go quite a lot into the social determinants by still talking about services. So we're talking about this range of services, but the services are allocated according to need. And, some people objectively need more health services than others. That very moving example that Joy gave, where's Joy gone? Joy gave of Marshall, he needed his legs fixing. And, then therefore, according to this definition, he should have had that done. And it's unacceptable that situations like that are not being treated. But the full range, going right through to palliative care, we haven't heard that mentioned today, as an issue that, we need to make sure that end-of-life care is covered as well. So from that definition, which I'd say is all based on rights and equity and fairness, then I think it is resurrecting, sort of the notion of the pre-Alma-Ata, the primary health care, the health for all sort of movement. It is about everyone getting the services they need, but now this is the other interesting aspect, with the financial protection as well now. It's sort of explicit that in accessing these services, we can't have the situation that people are plunged into poverty and, obviously that's affecting their health and welfare. But from this definition, it's very, very profound, because I haven't got much time. It is absolutely blindingly obvious. You can only achieve this when healthy, wealthy people are subsidizing services for the sick and the poor. And that means you've got to publicly finance your health system. You cut to the chase that if we're serious about universal health coverage, you can only do it through public financing, where wealthy people pay in more than poor people, and people with no money don't sort of pay in directly anything at all. Now, that's very challenging to some ideologies, and I think that even in the early days, and interested in the slide that Socrates put up there, there were sort of whiffs almost of sort of community financing in some of the definitions there. Something about maximum reliance on available community resources while remaining within cost limitations. That sort of smacks to me sort of somewhat of, we're going to expect, communities to pay for this. You sort out your own healthcare and don't expect the rich people in the cities to pay for the poor people. No, that's wrong. If we're serious about this, we've got to be talking about a publicly financed system. And then again, we in the health sector can get, particularly health economists, can get all het up about, are we talking about compulsory social health insurance? Or are we talking about general taxation financing? Is beverage better than the Bismarck model? And again, that's just confusing things. Because at the end of the day, they're both forms of taxation. You've got to tax finance your health system. And that goes for this country too, big time, if you're going to achieve universal health coverage. Now, in the presentations there, it was interesting. I think there's been a bit of sort of criticism, I think, for a technocratic approach, and we heard it a bit this morning as well, to defend Refat and the comments here. We do need to spend our money wisely. You do need to strengthen health systems. Undoubtedly, you do. We need to demonstrate that we're spending money efficiently. So, that goes without saying. It's also very important, and I think sort of we heard it in sort of Rama's sort of presentation as well, that we don't associate universal health coverage with health insurance. Now, this is a huge worry, and I can completely understand from India's perspective why you're seeing this, that the Ayushman Bharat reforms in India are dominated by hospital insurance, aren't they? That's basically sucking people into private hospitals. That isn't a good idea. That seriously isn't a good idea. And if the UHC movement sort of gets captured by this idea, and Refat was almost alluding to it as well, that health insurance is coverage. No, that's not right. What we're talking about is coverage of services as well. The coverage refers to coverage of services and coverage of financial protection. And it's those two elements together is what we're talking about. But then we might have to face it. We've got problems with the terminology, and if we are losing it, that people are associating it with health insurance coverage, we've got problems. But I think one of the most important comments that was made was Joya's when she just said, "We need more money. We need more money." I mean, for virtually all the services and the groups that we're talking about, what we're recognising is that we need more public financing, be that domestic financing in many situations, augmented with external public financing, so aid financing. But that then leads to the big question: how are we going to get that? And often these conferences, sort of end with this situation: yes, we need more financing, and what do we need before that? We need more political will. And that is true. That is true. And it's unfortunate my time's run out just at the point when I was going to sort of, but if you just give me sort of 2 or 3 minutes, this is what we need to be getting better at generating the political will that comes up with the public financing. And I think this is where we need to be smarter. And instead of restating the problems and complicating things and say having big UN events on NCDs and say, oh, NCDs is the most important health thing this year, and confusing people about the relative priorities. The universal health coverage notion that everyone gets covered and basically the state finances the health system, politicians understand and populations understand. All these sort of pictures you see of people taking to the streets are in effect people saying, we demand our government to fund health services. It might be for a particular area, or it might be in general. I and my family take to the streets on a regular basis in London. If it's not about Brexit, it's about the NHS. And sometimes it's the two at the same time. And it's absolutely obvious thing that populations can relate to heads of state, to prospective heads of state, that we demand this. And I think we need to be clever at pitching to political leaders. We sell the health benefits quite well, but flog that to death. We aren't so skilled at selling the economic benefits, of which there are absolutely tons and tons and tons of evidence. But one area, amazingly, we almost always neglect are the political benefits. If you do this, you will become a national hero. You will get re-elected. You will get power. And it's just the most obvious thing. And then again, relating it back to my country at the moment, where we're just going through this awful experience with Brexit. But when the political temperature rises, you can just see that, our ghastly government reaching for this thing. Let's chuck some money at the NHS. And, that's the way to sort of, make the British people happy. But in some situations, that message isn't getting through to the politicians, that if they sort out the health financing system, this can really sort of turn around the whole country. So I think what we need to be doing as a UHC community is rallying behind this, because politicians like it, hold them to account so they don't sort of have reforms that perhaps like sort of being sort of trumpeted in India at the moment, that is benefiting population groups above others. But in selling this, that we sell them the political benefits, and then we're going to be more likely to be successful in getting UHC, Health for All, PHC, whatever your acronym. Thank you.
We'll just stay here. We'll have some questions. I've always found the concept of political will lacking, and it's sort of an empty bag in which we stuff many things. Now, you're a political economist, and I think it's important to have a political economist talk, because it shows that behind the technicalities of the economy is power, and that's what the political brings to this. But it's also important to remember that when Adam Smith wrote The Wealth of Nations, in a sense, kicking off the rationalization of what commercialization, markets, economy would be like in modern times, he wrote a moral text. The Wealth of Nations is a moral, anyone who's read it can see right away, is a moral text. Because the argument that Adam Smith makes is that you can have a commercial domain. It's very important, and there is, for Adam Smith, a hidden hand that will work out things in the market. But that's only possible for Smith because of religion and the moral domain. And infiltrating religion and the moral domain with the market, Adam Smith makes clear, is untenable, unacceptable. So one of the questions I have for you is how to bring more specifically politics and the moral domain together to make financing of health much more significant. And let me actually ask you about a strategy, the one that's occurred to me. So in this university today, we're having a university-wide debate about what is the most existential threat to in our times. And a group of faculty have argued that environmental change, warming of the globe, and climate change is the fundamental existential threat of our time. And that therefore we should do certain things for that. The issue here is that we should get the university to stop investing in its $41 billion endowment in fossil fuels. But that actually for a university, in my view, is small potatoes. If something is an existential threat, it should require a university like this one to go out and raise $1 billion to make what we do, the teaching and research relevant to climate, the best in the world and the most useful for the world. So let's look at health in that domain. We could make the case that health is in fact always the central existential threat and concern. If that is in fact the case, then in this country, in the United States, why do we get so excited about 17% of GDP going for health? We would almost want to reverse what we give to the military and what we give to health, because health would be seen as the fundamental existential threat to individuals and families. So this is my question to you as a political economist. A, is there a strategy we can follow that would allow us to make this kind of claim effectively with populations? And B, is it a good idea at all?
And I think you're right to raise this issue of tactics and strategy, really, because you can sometimes analyze this stuff to death, and the people looking at political economy will often sort of analyze and not sort of get stuck in and sort of see what works in persuading leaders. I think that one of the skills is to sort of turn the message around. So instead of frightening politicians, saying, there's this terrible thing out there and you must stop this or we're all going to die, particularly if the threat is a long way off in the future. I think this is one of the problems about sort of encouraging people to invest in surveillance systems and preparedness. They think, oh, well, chances are it's not going to happen. And if it is going to happen, we're all going to die anyway. So why should I bother about it? So, but if you can sort of turn it round and then present it as a situation of like, look, there are lots of people really upset and angry out there, and there's a real problem, but you could be the person who solves this. This will be a very positive message, that in doing a few simple things well, and around investing in primary care, but also in your hospitals, and that you providing a comprehensive package of services. The surprising thing about health is that you can turn a health system around very quickly. There are quick political wins in it. And I think you've got to be getting into the mindset of a politician, say, coming up for an election in a year or two's time, thinking, crikey, I'm behind in the polls at the moment. How am I going to get re-elected? And I think that we in the health sector, and in dealing with health, because it is so emotive, and every household in the country at some, during a year will have some health worries one way or another, that if you can help a politician improve the well-being of the population by tackling health, it's just such an obvious way that they become more popular. I used an example, actually, if you don't mind me sort of showing this, that I went to the Labour Party conference in Liverpool last year, and I went to the gift shop to sort of try and buy some souvenirs and just see what there was. And there were lots and lots of memorabilia about the current Labour leader, Jeremy Corbyn, not surprisingly. There was nothing on any other Labour leader, Gordon Brown, Tony Blair, all these previous leaders, apart from Nye Bevan, the architect of the NHS, the architect of the NHS. And I sort of bring this to some of my presentations. And so, here's a sort of a tea towel. Sort of say, a society can legitimately call itself civilized, cannot call itself civilized if a sick person is denied medical aid because of lack of means. No. And when I sort of give these types of talks, particularly to political audiences, sort of say, look, if you want to be on details in 70 years' time and lauded as a hero, this is what you do. And I think it's the message that needs relaying in South Africa, Ghana, Kenya, India, Indonesia, these countries where they're just flatlining at 1% GDP public health spend, that, this is how you become...
Of course, Aaron Bevan was thinking of his father and his chronic lung disease, having worked in the mines.
Absolutely.
Yes, we'll have some questions, yeah.
But please, I think...
Sorry? Yes, let's call all the presenters down now and turn it to a general conversation. Yeah.
So, along those lines, are we really going to end this conference still talking about how to reform the health service and how to get political will? Because the reality is that in many of our countries, you can't go to people and say, would you like to be on a tea towel in 70 years' time? Or would you like to be a hero because you'll be known for doing X, Y, and Z? The issue is that the reason why there isn't money to put... we want you to take back to Britain, to the politicians, that all the money that they stole from Africa and Asia, that they must find a way of giving it back so that people can build their own health service. Mm-hmm. But the problem is, in Zimbabwe, I don't want them to give that money to the current government. Okay, and there's no point in my going to my Minister of Health. And I think let's not make Zimbabwe exceptional. Malawi is the same, Zambia is the same, even to some extent Botswana, which is supposed to be squeaky, is the same. You can't go there and say, okay, we're going to give you all this money. That's what happened with AIDS. Lots of money came in and it destroyed many of the health services. So I hope we're not going to end without people paying attention to what Eric told us yesterday, which is that we have to change the whole system. The way that we tackled, the way that activists in HIV all around the world forced the pharmaceutical companies, forced governments to take these things seriously, was by having very focused, spirited campaigns, including throwing paint at buildings and in conferences, etc. Are you going to say we should, that's all outside of this room, we'll rely on civil society organizations outside to do that, and actually we'll just keep debating the difference between coverage and care? Is there nothing that can come out of this conference that says we have to tackle the economic injustices between the countries that have stolen money? No, that's what I want to hear, to take back.
Yes, we hear what you want to hear. We hear what you want to hear. And I think that we have a group of people who presented today who now should be given the opportunity to respond, not just to what you want to hear, but to other questions. But let's start with this question of economic justice.
May I follow up on this, because it's a related question?
Okay, yes.
So I wanted to invoke my own country, Canada, which has achieved UHC, whether you call it coverage or care, and it does have as its elected national hero again and again, Tommy Douglas, the Premier of Saskatchewan, who helped push this forward starting in the 1940s, fought against the docks, et cetera, et cetera. And yet, I would label my comment, and in conjunction with Sunanda's comment, why UHC is not enough. Canada has the highest child poverty rate among OECD countries, excluding Mexico. We have horrendous differences in health and life expectancy between First Nations, Indigenous peoples, and the population at large. Yes, we have coverage for migrants, and including migrant farm workers, but as soon as they get sick, they get kicked out. So I think if we continue to focus on UHC without coming to what I see as the crystallization of the Alma-Ata Declaration, which is calling for a new international economic order, then we are simply deluding ourselves. Yeah. Thank you.
Yes. Okay, so I think this is a very, very useful way to get our panel activated. Let's make this a debate on that question, which is it an issue of fundamental justice and the reformulation of systems of care everywhere? Or is it an issue of dealing with primary care as the locus of what the experts in the room are expert in, and where they think they can have some intelligent contribution toward change? Or is it that the polarizing that and making it antipodal is wrong, and that we can leave here with both, addressing both concerns? So let's turn to the panel. Joya, do you want to start?
Sure. I think that we don't all have to be activists, but I think many scholars should be and actually are activists. I don't think we're waiting for civil society. We're part of civil society. We are the beneficiaries and often the actors that create these problems, and sometimes are the beneficiaries of inherently unequal wealth. But I think there's multiple strategies. When you look at social change, one of our faculty, Julius Richmond, used to talk about having the knowledge base and the social strategy and these different aspects of change. many of you are scholars and produce amazing work that can be used in action because we know what works, what doesn't work. Many may want to take up the activist cause, and then others are implementing the work and just showing that things can be done. And I really disagree that HIV money wrecked primary health care. In many countries, it was only HIV money that provided health care for people, and it so much depends on the engagement of people on the ground and how money is used. And I believe that, we talk a lot about social determinants, but I think what we've come up with here is that there are indeed social forces. They have a magnitude and a direction. They're not just deterministic. And this magnitude and direction has a very long historic tail. It is combined with the politics of the day. And so we need policies to push back on that magnitude and direction, indeed to change the vector, but that can be done through a variety of things. And I think when you look at what's happened with the attention to climate change, I mean, the UHC meeting at UNGA was very, very, very quaternary compared to the climate summit, not because the powerful care about climate, because people are taking action. Now, that action hasn't borne fruit yet, but I think we need to think about how do we engage in concrete actions that also look at the intersectionality between climate, health, education. In fact, the poor are at the front lines of climate change as well. And, from countries like Malawi that is in a constant cycle of flood and drought to, some of the first cities being wiped off the map in Mozambique from climate change, the health impacts of that are profound. So I feel like activism is key, but that takes the need for scholarship, the need for understanding what can work. My work with Eric Sawyer over many years was because Partners in Health had a model of care that could be used by and with activists to show that something can be done.
Please, yeah.
I just want to reiterate what Joy said. I think it's very important to form alliances and they're very often driven by ideological considerations. A lot of people don't like the word ideology, but I think it's extremely important here. And I think it's not just about civil society. What I heard from Sunanda yesterday, and it occurred to me, it's very true of India as well. So whether you take any of the big national programs, the perception of what is required at the community level varies from the doctor down to the frontline workers. And I think somewhere we need to acknowledge that those alliances are not alliances we've explored adequately. Because when you talk to middle-level workers, they'll tell you how, they acknowledge poverty, they acknowledge the real lives of people. But when they talk to their higher-ups, they're not interested in listening to it anymore. So I think we really need to be a bit more creative in the alliances we make. And also within the doctors, the community of professionals, there are people who care, but their associations don't represent their voice. And I think it's time to sort of build those alliances across various professional groups, considerations of those kinds. And I think one of the greatest challenges is commercialization. And I want to say that again and again, because the power of, I'm talking about India, which has a very strong corporate presence today, unlike maybe parts of Africa. They are, the role that they play in redefining what is health and the kinds of partnerships that are built with technology to deliver and redefine what is required in terms of universal health coverage is, I think, very important for us to engage with.
Thank you. Socrates.
The thing that comes to my mind is the role of history and good examples in all of this. Looking back to Alma-Ata, we had health by the people. The films that were presented at WHO to illustrate primary health care were ridiculous. Right? There was a health promoter in the Andes who was preaching tomatoes. She was dressed in a nurse's outfit and she was promoting food that was totally not available locally. Have there really been any, I won't say progress, but the focus, the other thing that pops into my mind, if you look at the publications that come out at big meetings and you find 100 pages, you find a little box that says this is a success story, right? And that box is supposed to, this is energizes. Well, that's a ridiculous thing. Now, can they do more than a box? I mean, I'm not an activist, but I could imagine that there are ways of promoting success stories in a way that attracts more attention. Whatever it's glossy, it's got to be, but not a box. It's got to be more than that. Thank you.
Yeah, I think that's terrific. Let me now turn to our discussion. And maybe I can make one point before, just to illustrate Socrates and use a social theory here. Bob Merton's great theory of the unintended consequences of purposive action, of social action. The unintended consequence on the policy level of the barefoot doctor movement in China was to destroy primary care in China today, which is that barefoot doctors were so incompetent as caregivers, though so useful as public health workers. When it came to the local people understanding of what you did not go to a local practitioner for care. You went to the tertiary care hospital, and that's exactly where China is stuck right now, as an unintended consequence. We haven't heard this morning enough about unintended consequences. Please, yeah.
Yeah, thank you. And just to be clear, I'm not suggesting for one moment that the UHC is sufficient in solving, let alone the health problems, but sort of bigger societal problems. And the whole issues around income distribution, taxation, sort of colonialization undoubtedly need doing as well. And in fact, you could argue if those could be tackled, they would have a more profound impact. But I suppose the point is that, we need to move on things, incrementally and take big steps that work. And this is a big step that does work, and that the benefits go way beyond the health sector. This is the whole point, that if you can galvanize a health system and take it from a very low public spend to one where you're putting in 1-2% of GDP, covering the entire population, spending money wisely. And if you see the graphs of public health spending, they do take big steps up. Thailand did it in 2001, Korea did it in 1977. These are truly transformative processes that do impact on reducing inequalities, health inequalities, income inequalities. The Japanese tell a great story about how important it was to post-Japanese development after the Second World War. So if we can excite and engage politicians, this is a smart thing to do. And I would very much say that we can get to them. This is the whole point, that if we, using our various networks, using our political leaders, as well as working for Chatham House, I work for a group called the Elders, which some of you may have heard of, who are having these conversations with heads of state, and did with President Ramaphosa in South Africa just last month, looking at the benefits of South Africa basically replacing its apartheid health system. I mean, it hasn't changed much in the last 25 years, to be perfectly honest, and it really ought to have done. And having this really frank discussion about how great this would be for South Africa to, in effect, launch an NHS, and that this would have great health benefits, economic benefits, and could be a game changer for the government. And I think that, this is pretty big stuff, and that we can, given Harvard University, heads of state come through here on a regular basis, they come to Chatham House, that we can get to them and influence them, and this is what we should be concentrating on.
Yeah, I'm not against influencing heads of state. I think it's a part of a strategy, but I think it's only part. And when you look at human rights today, we are still in a post-World War II framework that each nation state on its own bottom, which is a lot like Harvard's run too, each tub on its own bottom. And so we have accepted within human rights what countries can afford. We're happy with the Universal Declaration of Human Rights. And yet that really is about what a nation state does or does not do for its people based on the resources of that nation state. And yet every single one of us in this room is wearing clothing from at least 4 countries. We are all the beneficiaries of globalization, and there are victims of globalization, and there are people who have not benefited from the free transport of capital. And I really think we need to look at what should human rights look like in the 21st century. What should human rights look like in this era of globalization that has mostly been driven by privatization and corporate profit? I think we have to re-look at how we construct society in this globalized era and who is responsible for human rights. We can say, oh, the government of Haiti ought to put more in. They ought to. But they are multi-trillions of dollars in debt when you count colonialism, slavery, the economic embargo led by the United States starting from the time of Thomas Jefferson and the World Bank. So, really, to say whether they can put more in or not, I wish they did. But that is not the fatal flaw of the Haitian health system.
Yeah. If I can just say something to make it even more complicated. You use Japan as an example because they have the most outstanding long-term care system of all countries in the world. But in 2040, and we right now, by the way, I used to be the head of Harvard's Asia Center. You're in the space of the Asia Center right here. So this is an appropriate comment. In 2040, 40% of the Japanese population will be over 65 years of age. It is impossible for Japan to maintain its healthcare system that it has today in 2040. What?
No, it's inevitable they're going to have to spend more of their GDP, and that'll be a political choice.
Yeah, but they're going to spend more of their GDP with 40% of the population over 65 years of age. Yeah. For China, that's going to mean today that China is going to have to spend more of its money when not 4 workers, as we have today, for every retiree, but 1.5 workers for every retiree. I would say impossible.
No, I disagree.
Yeah.
I mean, the United States shows that you can spend 18% of your GDP on your health system.
Yes.
Not recommending that.
Right. One third of it wasted. One third of it wasted. One third of it wasted.
But that were the Japanese or the Chinese in the 2040s not that far off. I don't think they'd have to get to 18%, even though it's sort of 12, 13. But then that would be a political choice.
Yes, it's a political choice.
That countries will have to make.
Isn't it also about globalization, Rob? I mean, who does the majority of elder care in this country? People from poor countries, Haitians, Guatemalans, Nicaraguans. So who is caring for the sick in this country? Yeah. We are the benefits again of globalization, and so I think we cannot think of the nation state alone. We have to think of what is our core collective responsibility to health in a cosmopolitan way.
Yeah, I agree. I mean, I think what we're hearing today is wonderful. On the other hand, I'm reminded of Voltaire's great statement, utopia doesn't count. And can we actually have these things happen? Can we actually have these things happen? Or are we going to see what's much more likely, that the world is going to be the world we're accustomed to, but with additional constraints? And I think that's maybe what we should be thinking about. How will we face a world with additional constraints, where maybe health, even the idea of planetary health, may diminish in the face of seeing environmental health as the great existential issue. I'm just raising this to make it more difficult as we think about what's next. Let's have some other questions for our panel. Vikram.
I wondered whether the panel could comment on the role of foundations, particularly in the least resource countries in the world. And I was interested in particularly your comment, Rob, but also Joya, where you work, in actually distorting the health agendas by focusing not on giving money to the government to actually increase their dollar spending, but actually forcing them on very specific northern-led agendas. Yeah. And the second very brief point was also about the political will argument. In India, I don't think actually the idea of health being a primary, and actually this is for you, Rama, if it was the case that good health should win elections, the Congress should have won the election because the dramatic improvements under the investment in the National Rural Health Mission is unparalleled, and yet they lost. And I kind of wonder whether, in fact, this idea that health is a politically important good really works across all cultures.
Please, yeah, please.
No, I think you're right about what is on the political agenda rather than the political will. And I do believe that we need to unpackage the nature of politics. I mean, and what is the kind of political formation? Because if you're going to be looking at some of the parties, I mean, in a country like India, you're looking at the state and the center, right? And there have been states that have been innovative in the way they have approached the issue of health. Some of it we agree with, some of it we don't. Including this question of insurance-led coverage didn't come up at the center initially. It came up in the southern states, and they innovated it as a way of, dealing with the inequities in their own understanding. But more importantly, I think the way they conceptualized it, it gets mixed with populist politics. Yeah. And the political imagination is, what is it that I can put in which will help me to win the next elections? And actually, that's a great ally of insurance, because if you're able to increase insurance coverage, then the result of that is you do capture the votes of a certain section of the population. So I think somewhere for all our countries, we have to look at what is the politics and what is the nature of the political alignments that influence even the health question. Because today Ayushman Bharat is on the top of the agenda of the government. That's also an expression of political will. And he went into elections with Ayushman Bharat. And I think it is one of the populist schemes that helped him to win with such a majority. So I think we have to sort of really contextualize this process of how politics has played out in a particular way. And it worries me that I think part of the success of the Congress government was it was a coalition. The moment you have coalition politics, you have the space to leverage new ideas. Why is it that NRHM incorporated people like Antia and all the 1970s community health people into the decision-making process and into the committees of the NRHM, the National Rural Health Mission? Why is it that none of us are ever invited to any meetings in the Ministry of Health in Delhi today? And I think we need to think about the nature. Now we have a majoritarian government, probably for the next 10 years. So the spaces for any democratic engagement is getting reduced. And I think we need to really sort of unpackage the political context and the way in which, so we're not just talking about India, we're talking about Turkey, we're talking about Russia, we're talking about the United States. I mean, there's a particular moment in history where these formations are here to stay for some time. And I think that space is really shrinking in that sense. But on the foundations, if I may just come in, and I will then, I think you've raised a very important area of, we need to, I didn't talk about it in my talk, but I think we need to look at the corporate interests that back foundations and the way in which technology is then pushed as a northern agenda into southern context. And vaccines is a particular case, which I think is something we need to discuss.
Yeah, I think that's a great last point. I mean, if you look at the Gates Foundation, technological discovery is the basis of the foundation. Socrates.
Yeah, my comment is not quite direct to the question, but it's the role of civil society in all of this, and WHO's role. We haven't really talked about WHO at all. In the 70s, civil society were very, very important advocates of primary health care. The PHC NGO group, they interacted with WHO, they interacted with the countries, they made their statements at the assembly and the board, and they cooperated, how can they cooperate isn't right, they coordinated their activities in a way that their impact was far more than just the sum of voices, right? And I think we need to reflect on whether there's still a role for WHO and NGOs, because I think it's going to come out of the NGO community, civil society community, to pressure WHO to move in the kind of action programs that you people are recommending. Thank you.
Joy or Bob?
Yeah, thanks, Vikram, for that question. I think there are two problems I see. Well, there are many problems with how aid is dispensed. But foundations and the US government, I would say, leading the way with the push for privatization and these kind of sexy bingo card kind of innovations. And again, as Arthur said, these are, if you look at Gates, it's a Microsoft thing, but it's more than that. It's this notion that the captains of capital are just inherently smarter than the rest of us, and they could figure out an app or a gadget that will get us out of a system that's been caught, out of what we're dealing with, which is 200 years and more of impoverishment. And so I think there's an arrogance to it as well. So there's the idea that you want to focus on a quick fix. There's the sort of arrogance. And then in the United States, we are still working with the 1961 Foreign Assistance Act, which was written and is behind the creation of the U.S. Agency for International Development. The 1961 Foreign Assistance Act basically says, buy American, open markets for the United States, and don't support big government in other countries. So what we find with things like PEPFAR, it's not that the HIV money is doing it. The US government demands that you can't pay salaries of workers. So what does it create? A whole secondary cadre of a parallel system of people getting paid for, HIV services and internal brain drain. The US government says you can't buy generic drugs. You have to go with, pharma. The US government says you have to focus on religious organizations. These were all part of not PEPFAR, but the 1961 Foreign Assistance Act. And what does that do? That sets up this narrative and this actuality of privatization, even in the NGO world. And so, what you have this proliferation of NGOs that are doing vertical things, that are on a contract, and whether it's a foundation or the US government, I think the overarching narrative is a kind of neoliberal view of aid. And I think until we get rid of the privatization narrative, we're not going to be able to actually develop systems of care, which are really needed.
And there's a great example, actually, and an alarming one, just to illustrate Joy's point about rubbish projects, that sound flashy, but are damaging. And sadly, it was actually the World Bank president put it in his speech at the UN last. I'm not sure many people noticed it, but he was sort of celebrating a health financing app in Kenya called Mtiba, where people pay for health services with their mobile phones. And it sounds just really modern and sexy. You pay for your health services with your phone. It's just absolute nonsense, because there's no pooling, there's no sharing. You pay for your own health services. You might be able to transfer the benefits to your friends and your family, so well done them. But if you're a poor villager and you haven't got a mobile phone or people who are on direct dial with you, tough luck. So this is fundamentally incompatible with universal health coverage. And that in the 2-minute slot that the president of the World Bank had at the UN last week, he starts this nonsense. So sadly, we have to be really vigilant, and I think the track record of the international community on health financing has been lamentable, and that we need to hold them to account on this.
Well, all good things have to come to an end, and so let's give the panel an applause.